वक्रतुंड महाकाय सूर्यकोटि समप्रभा
वक्रतुंड महाकाय सूर्यकोटि समप्रभा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Good morning and welcome all. We will be starting today's first lecture, and it will be an innovative approach in diagnosing and management of diabetic nephropathy by Dr. Par Devgaonkar. We welcome you, sir.
Hello, good morning. I am Dr. Par Devgaonkar. Thank you for the opportunity given to me here to talk on this stage. So I'll be talking about innovative approaches in managing and diagnosing diabetic nephropathy. So we see a lot of patients nowadays with this problem, and we have new drugs to counter this menace that is, diabetic nephropathy. So basically, diabetic nephropathy is a clinical syndrome characterized by persistent albuminuria and progressive decline in renal function. Around 20 to 50% people with diabetes eventually develop some form of kidney disease in their lifetime associated with diabetes. And most of the patients, who are on dialysis in our setups, they have kidney disease because of diabetes mellitus. So basically, how do we diagnose diabetic nephropathy? So there is persistent albuminuria, which is confirmed on two findings 3 to 6 months apart, more than 30 milligram per day. Progressive decline in the glomerular filtration rate, that is rise in creatinine, and there is a presence of hypertension. What are the risk factors associated with diabetic nephropathy? The non-modifiable, the genetic factors, the male gender, longer duration of diabetes, race. So blacks have lot of incidence of diabetic nephropathy. Increasing age, family history of type 2 diabetes mellitus and hypertension. Family history of patients with diabetes having diabetic nephropathy, further generation, there is a higher chance of developing diabetic nephropathy. Modifiable risk factors, smoking, hypertension, poor glycemic control, low intensity of physical work, as well as dyslipidemia. So what are the histological changes associated with diabetic nephropathy? So as you can see, the above section, the above half shows the kidney with a diabetic nephropathy, and the lower half is a normal kidney. So basically, the first thing that we see is, can I have a pointer? The first thing that we see is usually glomerular basement membrane thickening, that is a podocytopathy. Eventually, there is a development of mesenteric cell hypertrophy proliferation, leading to tubular atrophy. So how do we screen for diabetic nephropathy? So how do we screen for diabetic nephropathy? So patients with type 1 diabetes, you start the screening after 5 years of diagnosis. For type 2 diabetes mellitus, the screening should be annual because we don't know the exact onset of type 2 diabetes mellitus. So how do we screen for diabetes mellitus? So usually we should do a urine quantification through urine albumin by creatinine ratio or a urine routine showing a positive dipstick protein. And this should be confirmed by two findings within the first 3 to 6 months to confirm the presence of diabetic nephropathy. So how do we manage diabetic nephropathy? So this is a nice pyramid. So this was recently published in the KDIGO guidelines. So most important are the lifestyle management, that is diet, exercise, smoking cessation, and weight control. So the first line drugs, will be discussing all this in detail. Metformin, SGLT2, the RAS inhibitors and statins. The newer drugs, that is non-steroidal MRA, GLP receptor 1 analogs, and the additional risk factor control, including glycemic control as well as blood pressure control. So these are the landmark trials based on which we have, based our management of diabetic nephropathy. So the first trials which were significant, and these were landmark trials, were the renal and IDNT. So the renal was with losartan and IDNT was irbesartan. We showed decreased incidence of kidney outcomes, significantly decreased incidence of kidney outcomes in patients with diabetic nephropathy. So these are all the SGLT2 trials, the Credence, the DAPA-CKD, EMPA-Kidney. I think these don't need to be discussed in detail because all these were very, emphatic in saying that patients who are on SGLT2 inhibitors have better kidney outcomes. The newer drug, the new kid on the block is Finrenone, which is based on the Fidelio and the Figaro, two trials. We'll be discussing this in detail. The newer drugs, so the flow trial, say this is a new landmark trial which has come out this year with semaglutide. The trial was terminated early. So GLP-1 RA will be discussing all these in detail. So what are the treatment goals? So the most important thing is preserving renal function. So how do we do that? We do that by controlling the proteinuria and controlling the fall in the GFR and reducing the risk of cardiovascular events and mortality. Also, patients who have diabetic kidney disease, they need to be more vigilantly monitored for presence of other complications like retinopathy, neuropathy, and foot ulcers. So this is the new approach. So all patients who are diabetic and have kidney disease, they should be on metformin and SGLT2 inhibitors. So metformin should not be given below GFR of 30, and if the GFR is between 30 to 45, the dose should be half. So basically, if patient has a falling renal function, you have to monitor the GFR, and patient should be on SGLT2 inhibitors. So how are the other drugs, preferred? So this is how we do it. So patients who have heart failure, preferred what drug is GLP-1 RA. Patients who want weight loss, we have GLP-1 RA. Where the cost is the issue, we give sulfonyl urea, the thiazolidinidone, and the AGS. And for patients who want potent glucose lowering, we need to use insulin and GLP-1 RAs. So these are the individualized HbA1c targets. So if we expect a higher life expectancy, the uh, glycemic control should be more aggressive. That we should target the HbA1c of less than 6.5. Patients who have macrovascular complications, if diabetes is advanced, patient is older, we go little, more less aggressive. The HbA1c target should be less than 8. So as you can see, the HbA1c target varies. So RAS inhibition, so 3.6.3, all patients with diabetes who have some form of albuminuria, they need to be on RAS inhibitors, either ACE inhibitors or ARBs. So how do we start these drugs? So this patient should be initiated in all patients who have diabetic nephropathy. This is very important. Uh, even if the creatinine is high, we see a lot of skepticism from the physician for initiating this drug. But they need to be initiated for control of proteinuria. We need to monitor the renal function. So if the creatinine goes up by more than 30%, then we need to review for the cause of the rise in creatinine. If it is less than 30%, that is expected, that is a transient rise in GFR. That doesn't mean that you stop the drug, you continue the drug and monitor the renal function. The SGLT2 inhibitors, so this is again as per the KDIGO. So it is a 1A recommendation now. All patients with type 2 diabetes and CKD, that is AGFR of less than low AGFR with proteinuria, they need to be on SGLT2 inhibitors. So how does SGLT2 inhibitor work? Basically, in patients with diabetes, there is hyperfiltration, which leads to impaired tubuloglomerular feedback because of increased absorption of sodium and glucose by the SGLT2 inhibitors. And with SGLT2 inhibitor, this increased absorption is stopped. More sodium is delivered to the macula densa, which constricts the afferent arteriole. So this is how both SGLT2 inhibitors and ARBs act together. ARBs act on the efferent arteriole, and SGLT2 inhibitors act on the afferent arteriole. So basically, with SGLT2 inhibitors, we decrease the blood the blood flow coming in, and with ARBs, we release the pressure while the blood is going out. So we have seen about the metabolic parameters. We have seen about the hemodynamic parameters. Which is not targeted is the inflammation and fibrosis. So we have a new drug for this. This is finerenone. So finerenone is basically non-steroidal mineralocorticoid receptor antagonist, which has been shown to reduce albuminuria, slow CKD progression. And this benefit appear to be independent of other nephroprotective treatments. So these are the main trials related to this. The Fidelio DKD, which was mainly for stage 3, 4, and the Figaro DKD, which was mainly for stage 1, 2 CKD. And the Fidelity, which is the analysis of both these trials together, and which has shown a remarkable 23% reduction in CKD progression with this drug. So how do we give this drug? So these are the guidelines. So patients, who have a EGFR between 25 to 59, they should be started on 10 milligram. If the potassium is less than 4.8, and if GFR is more than 60, we can give the full dose, which is 20 milligram per day. The potassium needs to be monitored at 1 month after initiation, and then every 4 months, and the dose needs to be titrated accordingly. So basically, at present, the recommendation is that you use non-steroidal MRAs in patients who are not tolerating SGLT2 inhibitors. However, now we are seeing a lot of patients who are on all these three drugs together, and maybe we'll have some new studies which will show combined effect of all these three drugs together. So we have these three pillars now of therapy: the RAS blockade, SGLT2 inhibitors, and the non-steroidal MRAs. So we'll head towards the GLP-1 receptor analogs, which might turn out to be the fourth pillar. So basically, they act by activating the GLP-1 receptor, slowing gastric emptying and stimulating release of insulin. Meta-analysis of cardiovascular outcome trials has shown that GLP-1 receptor agonists reduced kidney outcomes by nearly 21%. And this is how it has been postulated to act. Basically, there are both direct effects and indirect effects, and which the NHE3 channel, which basically the GLP-1 acts through and increases the natriuresis, reducing the hyperfiltration. So this is the flow trial which has come out. So the very interesting that they have shown the image of a reptile. If anyone knows why it has been shown, we'll discuss this later. So basically, this has shown that semaglutide has significantly reduced the risk of clinically important kidney outcomes and death from cardiovascular disease in patients with type 2 diabetes mellitus and chronic kidney disease. This trial was terminated early because of for benefit. So basically, now they are going to, I think, push this drug for management of diabetic nephropathy. So tirzepatide is another drug which will, in the future will, I think, come in the spectrum for management of diabetic nephropathy. So this is the SURPASS for post-hoc analysis. So we don't have trials for renal outcome trials for tirzepatide till now. However, this trial has significantly shown that the fall in GFR is less with tirzepatide than with placebo. So basically, what they have monitored for GFR decline based on creatinine and cystatin C. This is because with tirzepatide there is weight loss, and with weight loss there is decrease in muscle mass, which may affect the creatinine values. So they have compared it with cystatin to prove that there is actual renal benefit. So these are some of the new drugs which are tried, the endothelin-1 receptor agonist. However, these are the trials, basically the Ascend, Radar, and Sonar trials. We showed that this avocentan or atrasentan had benefit with decrease in proteinuria. However, there was a lot of events of fluid retention. So we have tried this new combination with zibotentan and dapagliflozin. It has more ET1 selectivity, the zibotentan, than the other drugs. So this is the Zenith CKD trial, which showed that when these both drugs were given together, as you can see with low dose zibotentan, fluid retention events were similar to placebo. The mean change in UACR was significantly higher. So maybe this drug will come along in the future for further as a further drug. So basically, combining zibotentan with dapagliflozin helps to ameliorate the fluid retention events. To summarize, these are the drugs for treatment of diabetes mellitus, with diabetic nephropathy. The classical treatment, including the glycemic control, blood pressure reduction, RAS blockade, lipid management, along with the newer drugs, including the SGLT2 inhibitors, the GLP-1 receptor analogs, and the non-steroidal MRAs, along with the tirzepatide. So all patients who have diabetic nephropathy should be on maximally tolerated RAS inhibition along with SGLT2 inhibitors. Pindronon can be added as the third drug. All the three drugs need careful monitoring with sick day rule. That is, you need to tell the patient that if he has some kind of dehydration event, loose motions, vomiting, he needs to stop these drugs to prevent episodes of AKI. And GLP-1 receptor analogs now likely to emerge as the fourth pillar in the management of diabetic nephropathy. Thank you. Any questions?
Thank you. If anybody has any questions. Yeah.
Mic is not working. Hello, hello. Can you elaborate proteinuria treatment with the Finronon in a hypertensive patient, like non-diabetic patients? How to go ahead and which drug is better? Finronon in what dose?
So
and how
as of now, Finrenon is not recommended for use in patients who don't have diabetes. However, we do try if the other measures fail in a similar way to how we use in patients with diabetic nephropathy. But as of now, the recommendation is to be used only in diabetic patients.
then how to deal with the patients of microalbuminuria and proteinuria in a hypertensive patient?
So you start the
S inhibitors,
RAS
all are
inhibitors,
going.
SGLT2 inhibitors, and if both are not working, if there is persistent proteinuria, you may add this drug with the informed consent of the patient. That these drugs you have used on basically for this indication. However, it has not been proven beneficial as of now.
Thank you.
Okay. Okay. Thank you,
Thank you.
Dr. Degonkar. So we are moving towards the next lecture. The next lecture is by Dr. Kiran. He is my best friend. And the topic given to Kiran is diabetes eye care in diagnostic and therapeutic innovation. To mention something, few good achievements of Dr. Kiran, he is a consultant in JJ Grand Medical College, which is one of the reputed government medical college in Mumbai. And he is attached to big hospitals in Mumbai, Wockhardt, Global, and other hospitals. He has got many awards to his achievements, and he is fellowship of so many fellows in diabetes in India. And the most important, he has got 27 publication, national and internationals, and he is author of few books, and he has got chapters written on eye care in RSSDI. Okay, so here the floor is for Dr. Kiran.
Good morning, everyone. Thank you, Chair. I'll be speaking on diabetes eye care, diagnostic and therapeutic innovations. And as a diabetologist, I will restrict myself to diabetic retinopathy. And so we'll be just talking about what should we know about diabetic retinopathy. And what can you expect over the next 13 or 15 minutes is like, why should it be a diabetologist perspective? Is there a need to create awareness?
Just nearer to us, voice, thought us.
Okay, sorry. Is there a need to create awareness and screen to evaluate the tools which are there for diabetic retinopathy and then therapeutic innovations? So if you look at this particular case, then there is a left-sided diabetic retinopathy and the patient has got a right-sided mature dense cataract. And so we cannot actually figure out what is happening in the retina. So as a diabetologist, please remember this, that blindness due to cataract is curable, whereas blindness due to diabetic retinopathy is preventable. It is asymptomatic. Every diabetic is a potential candidate for diabetic retinopathy. And as a diabetologist, prevention and development of diabetes or diabetic retinopathy should be our aim. Now, that's my paper, which particularly speaks about the asymptomatic nature of the microvascular complication or DR. And there is a lack of awareness and non-adherence to eye care, which particularly leads to poor visual outcomes. The most important part being that even if you ask a question, when was the first dilated fundus examination done, 72% of the individuals say the physician did not inform us that we need to even check the eye. Now, this particular picture is very important because it highlights the fact that even if you have mild diabetic retinopathy, there is no visual difference. So only and unless if you progress from mild to moderate to severe, then possibly you're going to develop some particular visual effect, and that is when actually the patients come to us. So if I look into the various guidelines related to models for screening of diabetic retinopathy, what is important out here is that we can screen diabetic retinopathy at our own clinics. Whether it's primary care, whether it's mobile van, anybody can screen for diabetic retinopathy. Every individual present out here can screen for diabetic retinopathy. And these are the tools to evaluate for diabetic retinopathy, but I will be highlighting these particular ones which have been mentioned out here, and I will limit myself to a couple of slides out there. So commercially available fundus cameras, I think many of us are being using these fundus tabletop cameras, which are non-mydriatric, 45-degree single field, which means it particularly shows you the optic disc and the macula. People have also started using fundus over phone, that is called smartphone-based cameras, and these are the ones which are available, including the DI and the Remedio one, which is the mobile on the fundus. So practically speaking, people have also started talking about, out of the box thinking. So practically using this mobile phone to screen for diabetic retinopathy. Sorry. Yeah. So that's my camera. And if you see, I do not have an ECG machine. Obviously, ECG machine would be there, but I've always kept the fundus camera next to my chair. And that's a bright light. What is interesting is you need to make the room dark. And once you make the room dark, particularly, see, the pupil gets dilated. Once the pupil is dilated, if you look carefully, you are also able to see the vessels inside. So there is no mydriation happening. Even in a non-mydric 73 years old patient, there is enough of mydriation wherein you can actually go and see the fundus of the patient. And what do you actually see? You see that's the vein, that's the arteriole, optic disc, optic cup, macula, foveal avascular zone, and that's the fovea. So this is what is normal fundus appears to be. And what are we looking for? All these particular things. Only except for this microaneurysm, which is a bit difficult for us to assess because that comes only with the experience. The remaining ones are all actually, everyone I'm quite sure will be able to appreciate it. So what is telemedicine in diabetic retinopathy? You screen at your particular place, you send it to your ophthalmologist, and the ophthalmologist takes or looks into the fundus camera and, the picture, the fundus photograph, and then diagnoses and helps you with the treatment. You counsel the patient and accordingly. So this is very important as far as rural and remote areas are concerned. And it practically helps. There is good amount of patient satisfaction, and almost 91% stated that it would increase the compliance to annual screening. So telemedicine in diabetic retinopathy is very, very important. We also have suppose if you do not have a fundus camera, then we also have something what is called cams on the move, wherein a bike or even a mobile van which is carrying this particular slit lamp fundus camera can be stationed right outside your clinic. What happens is you take the fundus photograph and it goes back to the hospital or the retina specialist, and that particular person again reads it. And then what you have is diagnosis, and it also tells you a treatment, whether you need an FFA, laser, surgery. So you can also have cams on the move. It's not necessary that you can have a fundus in your clinic. And suppose if you are still not very happy with the fundus, or you're not very trained about or knowledge about grading about diabetic retinopathy, what you can do is you can use AI, artificial intelligence, which has been approved in 2020. And when you should not use AI, if a patient is having diagnosed diabetic retinopathy, patient with prior diabetic retinopathy treatment, and patients having symptoms of vision impairment, you should not be using AI. And this is something which my son has done. This is the program. This is AI. Now this is actually a normal fundus. So how does it do, or how does it work using the Python programming? So it gives you a diagnosis saying mild diabetic retinopathy. So we have all mild, moderate, severe. But then what I would do is we also need to test whether this particular program is working good. So these are basically floaters in the eye. These are basically called vitreous floaters or asteroids. And these are not hard exudates. So So it shows an error, which means it's not diabetic retinopathy. Similarly, for any other person who's looking at this particular fundus image, it would appear to be an end-stage diabetic retinopathy. But this is actually von Hippel-Lindau syndrome in one of the patients. And we also tried this, whether it shows that and it shows error, which means it's not diabetic retinopathy. So this is AI. So you can grade it, and you can also help us with identifying high-risk patients. Now, the ophthalmologists have also been now using what is known as wide field imaging. What we use is anywhere around 45 degrees, 30 to 50 degrees, but people are now looking into 150 degrees field of view and 200 degrees field of view, which means you get right from the disc right up to the periphery of the fundus. So that's a wide field imaging. It helps us to localize the non-perfusion areas. It helps us to do targeted retinal photocoagulation and early detection of peripheral neovascularization elsewhere. Now, OCT plays a very good role as far as screening, diagnosis, management, and monitoring of diabetic macular edema, and that's a particular standard report from the Cirrus high definition OCT device. So what is OCT? Non-contact, non-invasive, micro-resolution, cross-sectional study of the retina. It's like an optical biopsy of the retina. So that's the layers of the retina. That's the vitreous, choroid, and the normal foveal depression. Just to show a few cases, that's the normal retinal report. Anything what is on the pink side, that is on the left, that the left, this patient is having left-sided diabetic macular edema, both eyes diabetic macular edema, age-related macular degeneration. At one particular place, OD on the right side, there is no image coming through. That's because there's vitreous hemorrhage and there's macular edema on the other eye. And this particular patient, again, we have a lot of vitreomacular traction in the right side is normal. So this is how the OCT helps us to identify the various structural images or damage happening inside the retina. Then moving on to fundus fluorescent angiography, which is considered to be a gold standard for effective diagnosis, monitoring, and treatment. Once you inject the sodium fluorescein dye, these are the various phases, which is not necessary for us. But what is important is that why do we use it is specifically for macular ischemia, unexplained vision loss, to differentiate between diffuse or focal leakage of, in cases of macular edema, and to confirm cases of proliferative diabetic retinopathy. So it appears to be like a tram-tack appearance. What is difficult is that it's invasive. You have yellowish of the skin, fluorescent green urine, possibly at times nausea, vomiting, hives, and anaphylactic reaction. So that's the fundus image, FFA, and you can see as the sodium dye passes through, the sodium fluorescein dye passes inside, you can see the microaneurysms, you can see the leakage, you can see the non-perfusion areas. This is actually what happens in an FFA. Now, moving on to one step ahead, which is called OCTA. It does not use dye. It's non-invasive. It uses the patient's own RBCs to actually show us the flow of what is happening inside the retinal vessels. So this is a fundus image, and if you can see, there is peripheral, there is NVE, and there is also a loop which has been shown there by the arrow. That is how it appears to be on an FFA. You can see there is dye leakage out there. Even the loop has been covered like a white spot out there with the arrow. But if you look into the OCT image, you will see those new vessels out there, which are NVE, and even the loop can be seen out here, which is very classically seen out there. So you are using the patient's RBCs to actually image the retina and not pushing any dye inside. So it's non-invasive. So CKD patients, I think this is the one of the best tool to be used. So it helps us to show the abnormal presence of flow or neovascularization, abnormal vessel geometry, that's central retinal vein occlusion. And the absence of flow, basically you can see there is neovascularization at the area of perfusion and non-perfusion out there. So this is, if you can, I'll just highlight it. See, this is NVD, and there is neovascularization elsewhere. Okay, and that is, this is also the FFA showing NVE. This is how it appears on the octa, and this is after the laser. You can see there is regression of the NVE, if not completely, as compared to the one which is shown earlier. In here, the retina guy has used the anti-VEGF. So you can see there's a small little PDR that's before and that's after. There is slight regression after the first anti-VEGF injection. Now, with respect to therapeutic innovations, good glycemic control, statins, fenofibrate, glitazones, SGLT2 inhibitors, does GLP-1 receptor agonist or DPP-4 inhibitor have any role, and what is the management for hypertension? So here is a case, type 2 diabetes, 11 years, A1C 9.8%. You can see the hemorrhages out there. And this is after 6 months. You can see the hemorrhages have classically disappeared. A1Cs come down to 7.6%. So with good glycemic control also, yes, we can achieve good fundus images, or you can actually do good treatment. So 1% reduction in A1C, there is the whole lot out there, 35% reduction in risk of diabetes and 15% reduction in blindness. Now statins, if you can see out there, it's very in the periphery out here, right? So after using a combination of fenofibrate or statin, you can see after 6 months, it's disappeared, right? So even statins are good. Fenofibrate, rosuvastatin, atorvastatin, whichever one you like, just use the combination and I'm quite sure you'll have excellent results. Glitazones. This patient has diffuse macular edema out there, and you can see once only the pioglitazone has been stopped, you can have a normal foveal counter after 4 weeks, which has been done on an OCT, and there is visual improvement out there. So just stop, and there is no anti-VEGF needed, there is no laser needed. SGLT2 inhibitors, I tried this and it's in publication. The ones in the blue are actually the OCT, the central retinal thickness before the use of SGLT2, and the ones in the orange are the ones after the use of SGLT2. And you can see there is a reduction in the central retinal thickness. Just to highlight a couple of cases, 7 and 9, you can see here the anti-VEGFs have been given, but there doesn't show there is no improvement. But the moment you add SGLT2 inhibitor, you can see that there is a reduction actually in the central foveal thickness, and you can see there is no anti-VEGF further needed. So SGLT2 inhibitor may have a protective role. Therefore, SGLT2 therapy may be a novel, non-invasive, low-cost treatment targeting glucose-dependent cellular tonicity regulation, depending upon the DME with stable outcomes. The role of DPP4 inhibitors, I would say yes. Retina is an ontogenetically a brain-derived tissue. So it is reasonable to expect the GLP-1 would be useful in preventing. Now, this is all in the experimental phases. It says that the GLP-1 has both neuroprotection as well as the microvascular protection. And it is based on the particular aspect saying that there is retinal neurodegeneration happening even before the vascular leakage. So you give topical administration of GLP-1 receptor agonist and DPP4 inhibitors. And these are the studies. They have used sitagliptin and sexagliptin respectively twice in a day, topical administration in order to prevent neurodegeneration in diabetic retinopathy. And this is the last slide. Management of hypertension is something which we have always been talking. This patient came with painless, sudden loss of vision, and you can see there is blurring of the optic disc. You can see the hemorrhage out there. You control the hypertension and the disc, and the hemorrhage is back, right? So create awareness, screen and appropriate referral, glycemic control and treatment of associated comorbidities is the best care of diabetic retinopathy. Thank you so much.
Yeah, so wonderful lecture. I think we got good message in the morning. I just want one question. Uh, like pioglitazone, we do use in our clinical practice in select patients, whichever indicated. Which patients you feel should not be given pioglitazone, or which are the tests to be done before starting this drug?
Yeah.
Do you feel?
So I think pioglitazone is one of the best insulin sensitizers. I think Dr. Panikkar actually walked out, but if had he been
Yeah,
around,
sir
then
is there.
you would have actually
Left.
accepted the fact it's one of the best insulin sensitizers after metformin. You can start pioglitazone. The point is, if there is a rapid weight gain, if there is rapid fluid accumulation in your lower limbs, if there is sudden appearance of anemia, these patients should then be actually be checked for diabetic retinopathy. The rule says that anyways, you are supposed to do an annual checkup for diabetic retinopathy if there is no DR, right? So that will actually screen your patient irrespective of whether the patient is on pioglitazone or not. But the point is, if there is a rapid weight gain, anemia, fluid in the lower limbs or anywhere else, then obviously you should be looking for diabetic macular edema.
Okay. Any question? Yeah, one question we will enter.
Very good presentation, Kiran.
Thanks.
And I wanted to ask you one question. These mobile cameras, I had a camp and they said keep post surgery, they will not be able to screen. So
Yeah.
is it the...
To be very honest, the image is very small. Yeah. If you compare it with the Carl Zeiss one or the images which I have shown you on Forus, it's very difficult to see. I did not show you the paper which has been published by us, wherein we are comparing the photographs which have been taken on this particular mobile phone, or sorry, the Remedio machine, and then taken on the Carl Zeiss one. There's a huge difference as far as the image is concerned. I would say no. I mean, whatever is seen on the laptop, you get a better image to see that thing.
Yeah, just.
Sir, there is... No, that is...
Did you finish?
It is only for the post-surgical or...
No. You can use it even before and after. It's just that post-surgical, as I said, the field of vision, that image is very small on your mobile.
Okay.
So that's the reason that they don't actually tell you. But before screening, you want to use, you can use it.
Thank you.
Sir, as we know, on the India, we are Many times the before the diagnosis or detection of the diabetes, there is the eyes are affected due to undetected diabetes. And usually one should do what you said, but I think you mentioned 70 or 72% of the patient were not sent for the eye checkup when the diagnosis was made of the diabetes. I think that is very, though we are in the country, but I think that awareness is needed
Right.
to find out.
Right. Thank you.
Okay, this could okay. So next speaker.
Yeah, thank you, sir. Thank you. Moving ahead from retina to another important aspect of diabetes management, uh, glucose, weight, or vascular protection. What should be the my priority? And to tell about more about this topic, we have Dr. Pratap Jetwani. Sir is a MBBS, MD, FRCP, PG Diploma Diabetes, and sir is currently a National Joint Secretary RSSDI and past executive member RSSDI. Over to you, sir.
Thank you, chairpersons, for kind introduction. Thank you, Dr. Manoj, Dr. Purvi, Dr. Bansi, Professor Sashank Joshi, and the entire team of DRS WCPD for making me part of this talk. So I will start with glucose, weight, and vascular protection. What should be the priority? I will first start with glucose-centric approach. Is it more important as far as diabetes management is concerned? So we all know that once you are diagnosed with diabetes, particularly if your age is less than 20, you lose around 12 years of your life. And when in the age of 40s, then you lose around 6 years of life. So it is a deadly disease, particularly in younger individuals or those who are being diagnosed below fourth decade of life. The risk of complications is very high, and definitely they lose precious years of their life. So we need to focus on glucose control. Although the newer agents which have changed the way we treat type 2 diabetes, they were introduced for the management of hyperglycemia only. So glucose control is important, although they provide pleiotropic benefits, but definitely glucose control is there at the core of the disease. And we all know that diabetes is a disease related to blood sugar, persistent hyperglycemia, and if you don't control it properly, it will increase the risk of all complications. And if you control it properly, then you may prevent or reduce the chances of developing complications. Most of our patients, they are also having multiple severe risk factors, but this is there in around two-thirds to three-fourths of our patients, either obesity or old age or hypertension, dyslipidemia, smoking, or multiple other risk factors. Guidelines still focus on glucose control. Whatever guidelines you see, they say that you have to target HbA1c 7% or less in most of your individuals, although you have to individualize the target according to the various factors patient is having. And for that purpose, I think RSSDI therapeutic will is the way to go in clinical practice. This is the ADA 2024 recommendations that if you improve glycemia, it will reduce microvascular complications both in type 1 and type 2 diabetes. And there is no need to de-intensify therapy because now we have got new agents which are not associated with increased risk of hypoglycemia. So even when your HbA1c goes below 7 or up to 6, you need not to de-intensify therapy, which was the dictum previously. You can continue therapy and you can give your patients a very good glycemic control without the risk of hypoglycemia and a better outcomes. HbA1c control, we all know that it remains poor in India. This is the data from DiabCare India 2011 study, mean HbA1c around 9, and over a period of 1 year, it remained around 8.5. This is the recent data from ICMR in DIAB. This is published in 2022. A1C target less than 7 achieved only in one-third of patients. And when you go for all three targets, only 7.7% they achieved with significant heterogeneity between various regions and states. So we are still not doing good as far as glucose control is concerned. And we all know that as the HbA1c increases, the risk of complications increases. Also, hyperglycemia is not only a risk factor from microvascular complications, it is also a risk factor for all the macrovascular complications. 1% increase in HbA1c is associated with 12 to 43% increase in CV events. Therefore, glycemic control, if you achieve in a better manner, they have better chances of prevention of not only microvascular complications, but also the macrovascular complications. And there is evidence to support this. This is one of the systemic review meta-analysis published in 2022, where they have tried to find out the impact of intensive glycemic control on myocardial infarction outcome and major adverse cardiovascular events. If you see, this is the all available data of 14 RCTs, around 1.5 lakh patients. Mean age is 63.8. Mean duration of diabetes is 7 to 15 years, and mean follow-up period is 1.5 to 5.4 years. And if you see here, there was a reduction in MI to the tune of 10% when you combine all this data and do meta-analysis. At the same time, they have tried to find out whether there was any impact of glucose control. And if you see here, the above chart, when the patients were able to reduce HbA1c more than 0.5%, there was a significant reduction in MI. Those who were not able to reduce HbA1c less than 0.5%, there was a marginal reduction, but it was not statistically significant. So glucose control still plays an important role in prevention of macrovascular complications. The same is true for major adverse cardiovascular events. All available data, there is a reduction to the tune of 9%, and this is better if the patient is able to reduce HbA1c by more than 0.5%. So that means glucose control is important not only for microvascular but also for macrovascular complications. The same has been highlighted in another paper, that is systemic review with meta-analysis of CVOT trials and intensive glucose control trials. And all these trials, they have suggested that SGLT2, GLP-1, they should be included in the therapeutic plan of patients who are having type 2 diabetes and overt CVD. But at the same time, you should also focus on improving the glycemic control, because that will help you amplify the benefits of these patients as far as reduction in cardiovascular events are concerned. So this is the third data of CVOT trials, and they immediately, the conclusion is that glycemic control conferred by a wide range of anti-hyperglycemic therapies. So not only newer, but older also, they decrease MACE risk, but that is in an HbA1c dependent manner. So you reduce HbA1c, your risk of major adverse cardiovascular events will go down. This is a useful surrogate marker of CV events. But if you see heart failure, then it is more related with body weight reduction as compared to HbA1c reduction. So the message is clear: HbA1c control is required, glucose control is required, not only for prevention of microvascular, but also for prevention of macrovascular complications. Let's take a look at vascular-centric approach. Is it more important? We all know that the intensive glucose control trials, they have shown us that they may increase the risk in vulnerable population. Therefore, strict glucose control control may be avoided in certain group of patients. Type 2 diabetes, many patients, they are having NFLD, cardiovascular disease, CKD, heart failure, and all these things, they complicate the management of type 2 diabetes, because you have to focus not only on glucose control, but also on the prevention of this cardiorenal complications. And we Indians, we are having high burden of ICVDs. This is the data from multiple risk factors trial carried out in India. 39.5% they are having high risk, 60.5% they are having very high risk as per the Lipid Association of India criteria. And these are the multiple combinations which are there in our type 2 diabetic patients, which we encountered in our routine clinical practice. And we have shown that the cardiovascular outcome trials have definitely given us the clue that these drugs, particularly the SGLT2 inhibitors and GLP-1 analogs, they not only target glucose, but they also target body weight, they also target blood pressure and multiple other components of metabolic syndrome, and they translate into cardiorenal protection. So patients who are having underlying cardiovascular disease or CKD, you have to give them the benefit of these agents. And this is the data which suggests that although the HbA1c control is marginal with these drugs as compared to the intensive glucose control trials, the overall impact on MACE is still same. So that these drugs, they provide something beyond glucose control, and they provide cardiorenal protection because of pleiotropic benefits. And therefore, most of the guidelines, they recommend that patients who are having atherosclerotic vascular disease or multiple CV risk factors or heart failure or CKD, you have to use these agents early in the course of the disease, because they not only provide benefits in MACE and CV death, but also heart failure hospitalization, heart renal endpoints, albuminuria, and all-cause mortality. This is the ADA-ESD algorithm. We all know that patients who are having multiple CV risk factors or high CV risk, you have to use these agents on top of comprehensive CV risk management. This includes SGLT2 inhibitors and heart failure. Depending on the trial and other evidence, you may use either of them. Let's take a look at adipocentric approach. Is it more important? The concept was there way back in 2011 when they have suggested that adipocentric approach is much, much better as compared to glucocentric approach. Although at that time, no good drugs were available, so it was not the talk of the town. We all know that diabetes, most of our patients, they are either having generalized obesity or they are having visceral adiposity, which is the culprit for the development of insulin resistance, type 2 diabetes, and multiple cardiometabolic abnormalities. So you treat the pathology, which is the culprit for the development of insulin resistance and multiple cardiorenal abnormalities, that will go on their own. So adipose tissue, if you target, if you reduce body fat, if you reduce body weight, definitely it is going to have an impact not only on blood glucose, but also on various other cardiorenal metabolic meters. So this is the weight loss. This is beneficial across the disease continuum, be it early diabetes, pre-diabetes, or late diabetes. If you achieve weight loss, that is going to provide benefits. And therefore now this is the way you have to treat obesity and diabetes. Upstream approach, that is weight-centric approach, and glucocentric approach is now considered as the downstream intervention, because you are targeting once the disease develop and the setting of complications have done, then you are targeting glucose. But if you target body weight early in the course of the disease, you can prevent all the cardiometabolic abnormalities which are associated with excess adipose tissue. And weight loss is beneficial in reducing or improving cardiovascular risk factors at 1 year. This is in type 2 diabetes. Larger weight loss, larger the benefit, but up to 10%, 5 to 10%, there is an improvement in all CV risk factors. These are the various parameters which will be affected by weight loss. And larger the weight loss, if you achieve more than 15% weight loss, your chances of maintaining good glucose control without the need of glucose lowering medications will go high. And this is the data with surgery compared to medical treatment. People who are able to maintain HbA1c without the need for glucose lowering agents, that is much better with surgical treatment, surgical weight loss as compared to the medical management. That was way back. But now we have got different agents which can give you a weight loss equivalent to bariatric surgery. So if you achieve more than 15% weight loss, type 2 diabetes remission, CV mortality goes down, and heart failure with preserved ejection fraction gets improved. Various other amounts of weight loss, they have got impact on various other aspects of cardio metabolic abnormalities. So target of 15% weight loss is the new 7% A1C in type 2 diabetes, particularly if you are able to achieve early in the course of the disease. Lifestyle modification is there for weight loss, but we all know that it is very difficult to maintain. 50 to 80% of patients, they lose weight is regained within 3 to 5 years in most of our patients. These are the anti-diabetic agents, SGLT2 and GLP-1, which has got beneficial weight loss on top of HbA1c reduction. And nowadays we have got GLP-1 based therapies which provide excellent weight loss as well as impact on satiety and gastric emptying, thereby having an important role in appetite regulation also. So liraglutide, semaglutide, tirzepatide. I think semaglutide recently has shown also the benefits on cardiovascular outcomes in people who are having either obesity or overweight. And tirzepatide, this is the molecule which have changed the way we look at the obesity management. They can provide weight loss up to the extent of 10 to 15% or more than 15% equivalent to bariatric surgery. And the further newer agent, retatrutide, that is triple agonist, there is a weight loss to the tune of 25%. So guidelines now, they say that the selection of glucose lowering agents should take into consideration the individualized glycemic as well as weight goals. So now the weight has come into picture because now we have got good agents to target weight also in addition to glucose control. So this is the ADA algorithm which says that if weight is an important, then you have to use various GLP-1 analogs. And if intermediate weight loss is required, then SGLT2 inhibitors. So I have touched upon all the three aspects: glucose, weight, and vascular protection. What should be the priority? I will lastly say that multifactorial intervention is very important. This is the data from Steno 2, 21 years follow-up data. And if you see the curves which were separated at the end of 12 years, they are still separated at the end of 20 years. So be it mortality or CV death or CV events, everything is improved with the help of multifactorial intervention early in the course of the disease. And you can give your patients a good life for more than 8 years. The life is prolonged by around 8 years if you give them this treatment for 21 years follow-up. And this is because of prevention of cardiovascular complications. The same has been replicated in these various other trials where the intensive multifactorial control was carried out either in an early diabetes
Excuse
or
me,
in
sir.
patients who are having, just
Yeah,
I'm
sure.
completing. Yes, I'm completing. So intensified multi-factor control is important. Only thing we need to see whether it is effective in younger patients, and newer agents, they will add to the benefits if we use in this kind of settings. So diabetes requires multifactorial management of cardio, renal, metabolic risk factors beyond glycemic control. Glucose control may be priority in some patients, body weight may be priority in some patients, and vascular protection may be priority in some patients. But ultimately, it is the combination of all three which is required in most of our patients. And therefore, we need to use these newer agents which not only target glucose control, but they have got beneficial effects on body weight as well as multiple cardiovascular risk factors, and they provide cardiorenal protection. Thank you very much.
Thank you, sir, for the informative lecture. Moving ahead. Yes. If
So
there
question we
one
will
or
take
two
later
questions.
on. If
Okay.
okay, uh, there is a time problem is there. So we'll call the next speaker, Dr. Sanjeev Indurkar. The topic is diabetic lung. Okay, so very innovative topic, and I feel doctor has got a lot of experience. Sir is from Aurangabad. He is attached to many hospitals in Aurangabad, Orion Hospital, Medical hospitals, and he has got a lot of papers, presentations, and international, national, both. He has got a lot of positions in the associations of diabetic in India. So I think it is going to be a very good lecture for you. Just floor
Thank
is
you,
for you, sir.
Shabbi, chairpersons. Good morning, friends. I thank Purvi and Manoj for including this Hatke topic, lung and diabetes, in this innovation section. We keep on discussing all other organs they're monitoring, but we have neglected lungs probably for different reasons. Globally, if you look at this data from IDF Atlas 2021, it is very clear that with diabetes, the respiratory diseases, chiefly asthma, COPD, and OSA, are on the rise. And when they coexist, the outcome is probably worst. We remember the era of COVID. For the first time in COVID, we started thinking of lungs, respecting lungs, looking at functions of lung. And now in our clinical examination, SpO2 is a very important parameter. We look it and we plan the treatment. Unfortunately, after COVID, the viral infections are on a rise, and in every viral fever clinic, we are attending these issues. We look at restrictive pulmonary disease, asthma, COPD, and OSA. All these chronic diseases in individuals with diabetes are on a rise. They are almost 3 times, 2 times, 1.5 times, and they are to be taken care of when you are looking at diabetes. And when you are managing them, you have to respect blood glucose or diabetes. Certain common parameters, a common denominator exists, like obesity, physical inactivity, smoking, environmental factors, age, duration of diabetes, and very important, poorly controlled diabetes. All these parameters, they overlap in these two disorders, which makes sometimes difficult to pick up the disease. There are no specific guidelines, and the awareness, unfortunately, is limited. These are the functional abnormalities in the respiratory tract which have been demonstrated in patients with diabetes mellitus, indicating that respiratory abnormalities are there in diabetics, and they are bad or worst as compared to non-diabetics. The reason, the pathophysiology, which is though not completely understood today, but primarily it is hyperglycemia through these multiple mechanisms. If affects right from airway hyperresponsiveness, fibrosis, malignancy, inflammation, oxidative stress, and infection. So primary hyperglycemia has an impact on multiple aspects of chronic respiratory diseases. The 6-minute walk test, which became a very important test in COVID era, when patient was to send home, we were assessing them on these parameters. And it has been shown in all diabetics, these tests, while assessing respiratory infections, are compromised, and we have to respect them at a proper juncture. Association of diabetes and lung disease. If you look at spirometric parameters, they are definitely bad, deteriorated in a diabetic as compared to non-diabetic. Very important, we discuss duration of diabetes, degree of glycemia. Both of them, they affect the spirometric parameters whenever you look at respiratory diseases, whether this is duration or level of glycemia. And more the glycemic discussion, dysglycemia, the problems of respiratory issues would be increasing, and they would be more in clinical setup. Neuropathy, nephropathy, and retinopathy have been shown in these particular studies that they have higher prevalence in those who have neuro, nephro, and retinopathy. The respiratory issues like restrictive lung disease, spirometric test would be more abnormal in more number of patients. Beyond this interesting data also quoted that if the number of complications in a diabetic are more, 1, 2, or 3, all these spirometric parameters, they are worst, they are bad. So remember, duration, level of glycemia, more number of complications. I think you have to assess the lungs very aggressively and try to look at them. Coming down to asthma, which is coming up in a big way, and if a patient is hyperglycemic, the number of admissions in hospital to treat it would become more. So, in simple words, you have to tackle hyperglycemia in all respiratory, chronic, or acute diseases. Another bad news, if a patient has chronic hyperglycemia, he has chronic lower respiratory tract diseases, the mortality would be more in those who have uncontrolled hyperglycemia. Of late, last 10 years, obstructive sleep apnea is coming up in a big way with respect to obesity, diabetes, and the diagnostic parameters to do it, especially sleep studies, are available widely. They have been really respected in view of clinicians' vision. And it has been seen that obesity, OSA, diabetes all have bidirectional relationship. You have to tackle one by one so that the other responds. If you don't do it, both of them, they deteriorate. Controlled diabetes versus uncontrolled diabetes. OSA is much more common in uncontrolled diabetes. And I hope that many of whom you practice diabetes must have seen, if we tackle sleep apnea, put patient on BiPAP, the uncontrolled hyperglycemia settles down, insulin requirement goes down, patient loses weight, and ultimately he has less number of anti-diabetic therapy. How the concomitant medicines affect each other. We all know that use of beta 2 agonist, glucocorticoids, phosphodiesterase inhibitor, which are used in respiratory diseases, they increase, deteriorate glycemia. On the other side, if we treat infections in diabetics with antifungals and antibiotics, the glycemic levels, they drop down. Diabetes care drugs and their impact on lung function. We are fortunate that no antihyperglycemic agent is contraindicated in them, except if the patient has fluid overload signs, probably pioglitazone. We have to think twice, as it was discussed in previous lecture. There are some wonderful data coming up in certain class of antidiabetics, especially biguanides, SGLT2 inhibitors, and GLP-1 receptor agonists, that they have demonstrated protective effect against asthma and some other parameters. If we look at SGLT2, which has become a very important drug in diabetics, right from the goal till the end stage disease, the impact of this class on various respiratory outcomes, that is relative risk reduction, overall respiratory disorders went down by 25%. Acute pulmonary edema went down by about 50%, asthma 43, and sleep apnea syndrome by almost 65%. So this class of drug, which Jetwani rightly discussed in details with due respect to all benefits, in addition to that, probably it has a wonderful role in positive impact on non-infectious respiratory diseases. As we go further and look at these interesting data where empagliflozin reduced risk of new onset OSA, we all know that this drug is doing miracles, and this is one more interesting finding as far as OSA is concerned. Tirzepatide was discussed by both the speakers before me. In one of these two trials which were conducted with this molecule on patients with moderate to severe OSA and obesity, it was observed that this molecule reduces apnea hypoapnea index, which measures the severity of OSA, by about 30 events per hour, and very important, which we have been discussing, that weight by 20%. So probably in the era of these wonderful molecules, if we reconsider properly assessment and management of lung diseases, I think we'll be rewarded appropriately to tackle these non-communicable diseases which are coming in jointly with respiratory and obesity and diabetes. What about management? These are chronic diseases. When they combine, probably you have to look at patients' adherence to the therapy, proper physical activity, maintain healthy, balanced diet, which is extremely easy to advise, equally difficult to follow. We have to conceal for chronic nature of diseases, their outcomes, permanent long-term pharmacotherapy, and importance to the prescribed therapy. So these are common denominators for all chronic diseases, and when two of them they coexist, it becomes more and more important. Diabetes management: decide on appropriate A1C goal as per the need of the patient. If you have obesity predominant, if you have high A1C, young patient, OSA is there, probably aggression in treating hyperglycemia, weight, and targeting A1C as early as possible would be mandatory. And yes, of course, good goal to control glucose with multiple therapeutic agents, oral and injectables, would be required. Lastly, glucovigilance is important, and as rightly discussed by Jetwani, that weight is a very, very important area whenever you treat hypertension, diabetes, dyslipidemia, ischemic heart disease. You have to address this important parameter. By reducing it, we are going to give long-term, short-term benefits both. Lastly, I thank again Purvi and Manoj for including this wonderful topic, which I have reviewed in very brief: lung and diabetes, which has a common affection in millions of people across world. Diabetes affects lungs in multiple ways: structural, functional, and parapulmonary changes. The lung functions, spirometric, non-spirometric, are affected, and their deterioration is there if you don't control diabetes. high A1C, bad spirometric tests, and lastly, the spirometric parameters were observed to be significantly lower in diabetics who have micro and macrovascular disease. I have not looked at CA lung, acute lung injury, ARDS with time restriction, but they are also being affected by hyperglycemia. Before I close down, I would request that lungs are to be respected, assessed, and managed in every diabetic so that we justify these two chronic diseases, give good outcome. Thank you very much.
Yeah, it was a wonderful lecture. Uh, is there any question from audience side? Lung and I think we should have one diabetic nephropathy, retinopathy, lungpathy also in
Yeah.
future. I think so.
It's a high time to respect this important organ, which we suffered badly in COVID, including physicians treating patients and their family. So it's a high time to respect this.
So one question, if it is, if you like, the one drug empower SGLT2 inhibitors, what you said, it looks like to be a wonderful drug, like 42% reduction in asthma problems. So many 20, 25%. So do you feel that this is because of the effect on the volume, or it is because of anti-edema like effect, or it is like anti-inflammatory effect?
There are
What could be the
three
reason?
important aspects, Shabbi. One is definite weight reduction. And if you look at mechanism of action of SGLT2 inhibitors, there are huge modes through which it works. Unfortunately, their effect on lung has not been really studied to the extent what we wanted. But yes, today we can say it works, use it. Let us wait to see their effect and how they are working. We'll probably come to know in future. Thank you.
Okay, thank you, thank you. So
So
we are ending this session. For the next session, we'll call Dr. Okay, one group photo of all the speakers. Please come on the dais. Please.
Let me invite the chairpersons for the oration stage. Dr. Narayan Devgaonkar. Well, Narayan hardly needs an introduction to this crowd. A senior physician diabetologist from the city of Nashik, organizing secretary for the hugely popular RSSDI 2023, which was held at Geo. So we welcome Dr. Narayan Devgaonkar, and joining him there is senior physician diabetologist, close friend Dr. Kiran Shah, an integral part of the DRS family, to chair these sessions. This is the DRS oration, and may we invite on stage Professor Vijay Panikar. Let's hear it for Dr. Panikar. Purvi, if you can join me. So Diabetes Research and Solutions, along with World Congress of Preventive Diabetology, is privileged to award the DRS oration for the year 2024, sorry, to Dr. Vijay Panikar. Professor Vijay Panikar is the honorary consultant in the Department of Endocrinology, Diabetes and Metabolism at Leelavalti Hospital, Mumbai. Professor Vijay Panikar was a professor of medicine at KJ Somaiya College, Mumbai. He was the vice president of the Research Society for Study of Diabetes in India, was the chairman of the RSSDI Maharashtra chapter, has been the past president of the College of Physicians and Surgeons of Mumbai. He was the organizing chairman of RSSDI National Conference held in Mumbai in November 2023. Professor Panikar has contributed to chapters in various books, guidelines of RSSDI, and medicine updates. He has authored several research articles published in many peer-reviewed journals, and to many like us, he is a mentor, a man with large heart, and the room will be filled with his students owing a lot to him. We are extremely privileged and honored to offer the DRS oration for the year 2024. In fact, I'm getting goosebumps when I'm saying this. So extremely honored to offer this to one of our favorite persons in this field and on the planet, Professor Vijay Panikar. Are the chairpersons?
Hello. Good morning, everyone. Uh, Actually, Panikar sir is guardian of all the people here who are in the hall. And as Manoj already has done a very good introduction of sir, sir doesn't need more introduction than this. But sir, I think he will be the next future president of RACDI National. Sir is contesting for this post. So, when we all of are here, I think sir will be the next president. Sir, over to you, sir, for this oration. Already we are late by 15 minutes. Yeah.
Thank you very much, Manoj, Purvi, and your entire team. Thank you very much. It's indeed a wonderful gesture of love and affection. And I think यही मेरी कमाई है, सच्ची. The topic given to me is my journey with insulin. My journey really has been a long journey. I'm in practice for almost 45 years now. I have seen every aspect of insulin, right from the animal insulin to the purified animal insulin to the human insulins and now the analogs. I've seen them all, I have used them all. And that makes my journey very interesting because I have learned a lot in this. And maybe what I have learned may not be the right thing or wrong thing, but that's what I have learned. This is the evolution of insulin. You had pork and beef insulin, the purified insulin. I won't waste time on that. Look at this. This is the prehistory of sulfonylurea and insulin. The UGDP study, which came in 1970, said that sulfonylureas will increase mortality and insulin will reduce mortality. So this led some of the experts to conclude that sulfonylurea as a class was associated with increased cardiovascular mortality. And I joined medical school in 1971. My dad was a diabetic, and he was taking the first generation sulfonylurea chlorpropamide, which was named Dibenis from Pfizer at that time. And after this study came, his physician said, no more OHA, you should be on insulin. So he was put on those animal insulin, lente and plain, and that was my first interaction with insulin when I was in my first MBBS. And I thought, my God, insulin is the only treatment for diabetes today. As things went on, people criticized this UGDP study, so they did the UK PDA study, and they had three arms, conventional and intensive, which was sulfonylurea and insulin. And what did they find? That all three therapies had similar effect on HbA1c. And all three therapies had equivalent risk reduction of major clinical outcomes compared to the conventional therapy. So sulfonylurea therapy, no evidence of any bad effect. Then in 1999 came the Digami study. At that time, I was associate professor of medicine at Somaya Medical College. And what did Digami study tell us? This was based on the hypothesis that intensive intravenous insulin followed by intensive multi-dose subcutaneous insulin would reduce mortality in patients who have had a myocardial infarction. So we all started using insulin. And once a patient is discharged, you would be put on multi-dose insulin injection for practically a lifetime. So this was what was done there. And they showed that there was a reduction of 28% risk reduction if you put them on insulin. And if those patients who are not on insulin previously, there was a 51% reduction. Very interesting study. So we all started using, I started using insulin for all patients with myocardial infarction, post-myocardial, PTCA and all these things. But this study was suspect. There were a lot of things. In fact, if you look at the last 620 patients were out of 120 eligible patients were not included, and there was a big uproar. So they did the Digami 2 study. And here they had three groups, which was first just like the Digami 1. Second was initially you give insulin, but then continue the OHAs later, and the routine metabolic. What did they find? Overall mortality was lower than expected. Overall mortality was similar in non-diabetic population. And all the three glucose management, whether conventional or other, as long as you maintain the glycemic control, had very good results. So Digami study, what did it really tell us, Digami 2? The myth that insulin-based treatment lowers the number of non-fatal myocardial infarction and stroke was busted. Nothing. At that time, there's insulin causes plaque stabilization, prevents plaque rupture. Nothing of the sort happens. So sulfonylureas are safe. A lot of studies have shown that. But from 2008, the US FDA mandated that you should have a cardiovascular outcome. And one of the most important findings to emerge from this set of trials was that CV safety of sulfonylureas. Now, when you start a patient on insulin, my God, it's terrible. No, I don't want insulin, doctor. I'm scared of needles. It's going to hurt. So what are the patient's attitude? That starting insulin in a last stage mein aa gaya main. I'll get addicted to insulin. If started once, no other treatment will work. I can't inject. I will depend on others. Injection will be very painful. I'm all right without insulin. I can't afford it. And the patient's family, they believe insulin is the last stage of diabetes. He will get addicted, habituated. Who will inject insulin? कौन देगा उसको? डॉक्टर एक चांस दो उसको. अरे डॉक्टर वो 2 दिन पहले मिठाई खाया था इसलिए शुगर ज्यादा. All kinds of excuses. But at the doctor's end, that patient won't accept insulin. The moment I say you take insulin, he will go to another doctor. And this happens. Lack of time during consultation, worry of hypoglycemia, weight gain. So now today is the golden era for diabetics because all these drugs have become off patent. They're quite reasonably available to all your patients, and you can have combination therapy. And if you have triple drug combination, you can have 150 therapeutic options and quadruple 600, and so on. So all these combination therapies, we don't really have an evidence-based data to check out the correct algorithm. What has been our experience? Till the year 2000, we only had a sulfonylurea and metformin. And once they failed, we had to give them insulin. And we would control them with these three drugs. But then came glitazones in 2000. And we used glitazones. This is the initial where sulfonylurea metformin work, and glitazones started working in these places. This was the first paper that we published on triple drug combination of a pioglitazone, glibenclamide, and metformin in type 2 diabetic patients on insulin therapy. And what did we find? That HbA1c came down very nicely. The insulin requirement reduced by almost 73%. These are all patients who are on insulin. And 50% almost patients, the insulin was discontinued. And believe me, I got a reputation in Mumbai कि insulin बंद करने का है तो पनिकर के पास जाओ. No, actually, even type 1 diabetics started coming. We want to stop insulin. Because every patient of mine whom I stopped insulin would tell at least 20 other diabetics, अरे उधर जाओ insulin बंद होएगा. So this was the situation there. Then when this triple drug failed, we only had insulin again. But then DPP-4 came in 2008. Now the question is, can we use 4 drugs? Because all the guidelines say that after 3 drugs, use insulin. If you have to use the 4th drug, then replace one from the other and still keep it 3 drugs and give insulin. Now DPP-4, this is where it would act. And we already had 3 drugs on board. So this is how the functioning would be with this thing. So we did this study on patients who refused to take insulin and who were given a DPP-4 in addition to the first 3 drugs. And this was the paper that we published. Excellent results, and almost 80% of them got a good glycemic control, did not need to go on to insulin. When the quadruple drug failed, then again, insulin was the option, but then in 2012 came the SGLT2. So can we use SGLT2? See, this is where the ominous octet, we have almost covered everything except that kidney there. And SGLT2, what does it do? It just increases the glucose excretion by the kidney. It is not going to interfere with any other drug. So we added SGLT2. That's the 5th drug. And this is, again, patients who preferred not to initiate insulin. This is the efficacy of SGLT2 as a 5th drug. There again, I mean, good glycemic control, weight reduction of almost 3 kg, and almost 87% didn't need to go on to insulin. So when insulin is not an option, it is not the end of the road. Knowledge of each medication's benefit, safety profile, cautions, and cost are important in making the treatment decision. The ADA recommendation for number of oral antidiabetics to be used after initiating it said that any of the 6 treatment options, sulfonylurea, glitazones, DPP-4, etc., can be used with metformin. Now the question is, why intelligently treat type 2 diabetes? This is an average Indian, 30-year-old. He's expected to live up to 75 years of age. But if that 30-year-old is a diabetic at the age of 30, he stands to lose 14.5 years of his life. And that is what we are looking at when we are treating type 2 diabetes, not just controlling his sugar. And what do they really die of? 80% of them will die of a macrovascular disease, coronary artery disease, stroke, etc. Now we need to prevent that. This is the nurses' health study, which is done in almost over 1 lakh of nurses aged 30 to 55 years, followed up for 20 years. I won't go into the details of this study, but what this study really told us was that the elevated risk of cardiovascular disease began at least 15 years before the diagnosis of diabetes. I repeat, elevated risk of cardiovascular disease began at least 15 years before the diagnosis of diabetes. We are just being glucocentric. but all this problem is already going on. So the optimal treatment of type 2 diabetes needs a good glycemic control. That good glycemic control is responsible to prevent only microvascular disease. The macrovascular disease is because of the dysmetabolic syndrome, insulin resistance, obesity, hyperinsulinemia, hypertension, etc., etc. So based on this, what would be the drugs which could prevent or protect your heart? GLP-1 receptor agonist, liraglutide, subcutaneous semaglutide, dulaglutide have shown significant reduction in composite cardiovascular outcomes. Lexinotide, weekly exenatide, and oral semaglutide have not shown any benefit in cardiovascular outcome. They are not inferior to placebo. And these findings have prompted to make GLP-1 right on top in your list of medications for type 2 diabetes. SGLT2, unlike MACE, heart failure and cardiovascular death reduction is observed both in primary and secondary prevention cohorts. So now you had a GLP-1, you have an SGLT2 which has shown good cardiovascular benefit. Then we have the pioglitazone, which shows in all these randomized clinical trials, Proactive, Chicago, Periscope, IRIS, that it is beneficial. This is a comment by Robert Ryder and Ralph DiFranzo that pioglitazone is inexpensive, very effective at reducing HbA1c, no evidence of bladder cancer risk, plenty of evidence of cardiovascular benefit. So what do the guidelines say? This is the 2024 ADA guideline. It says patients with ASCVD, look at this. You give GLP-1 with proven benefit, or you give SGLT2 with proven benefit. But if HbA1c is still high, those who are on GLP-1, you consider adding SGLT2, and then you have the glitazones. So you have only 3 molecules which are really beneficial: a GLP-1, a SGLT2, and a pioglitazone. This is the 2024 ADA guideline. Now, what is the evidence of efficacy of insulin? It has been touted right from beginning, right from Degami study. Oh, insulin has pleiotropic effect. It reduces, it looks at the endothelium and it reduces the plaque rupture and stabilizes the plaque. Let us see what is the evidence. Look at this, major cardiovascular outcome trials involving insulin. No benefit. Look at this. This here first is your microvascular outcomes. Yes, there is microvascular. This Digami 1, Digami 2 has set it off completely. Accord, retinopathy, nephropathy, neuropathy reduced. But look at the macrovascular outcomes. No effect on, no effect, no effect, no effect, no effect. It does nothing to reduce the cardiovascular mortality. What about the mortality? None. But here in the Accord, there was an increased mortality. So where are we as far as insulin is concerned and cardiovascular outcome? Useless. It is just an anti-hyperglycemic medication. Look at the kidneys. Actually, 60% of patients undergoing dialysis are patients with diabetes. And the drug that has been found in the anti-diabetic armamentarium is the SGLT2 inhibitors. Consistent, impressive renal benefits are observed. Currently, there are a lot of studies with GLP-1 and agonist which are showing benefits in renal protection. Now, when you're treating type 2 diabetes, what is your main concern? A patient should not get hypoglycemia. वो रात को नींद में hypoglycemia होगा तो that is the tension a clinician has. So should not cause hypoglycemia. So which are the molecules that will cause hypoglycemia? Only 2, a sulfonylurea and insulin. So if you avoid using a sulfonylurea and insulin and you have got all these other molecules to use, you can sleep nicely at home without the fear that your patient will go into hypoglycemia. Should not cause weight gain. There are 3 molecules which will cause weight gain: sulfonylurea, glitazones, and insulin. Among this, the weight gain of a glitazone is a cosmetic weight gain because it reduces the visceral fat and increases the subcutaneous fat. And there are studies done by Ralph Differenza which says that those patients on pioglitazone who gain weight have the best long-term outcome. So that is as far as weight. So that again is sulfonylurea and insulin out. Now this is the ADA 2024 standards in care. I think you can't read at the bottom there, but what it says is sulfonylurea, efficacy is good, sulfonylurea insulin. On top is hypoglycemia, is maximum with sulfonylurea and insulin. The third is weight change, increase in weight with both these drugs compared to all the others. That's why it is shifted down right at the bottom. Effect on maize, neutral. Heart failure, neutral. Progression of diabetic kidney disease, neutral. What neutral means is it is useless. I mean, let's be honest about it. So insulin is the most potent anti-hyperglycemic agent followed by sulfonylureas. Both these molecules are generally only two which cause hypoglycemia, both cause weight gain, and are neutral as far as MACE and diabetic kidney. So what is insulin? Initiation of insulin therapy is recommended to achieve optimal glycemic targets, emphasizing the importance of timely intervention to prevent complications associated with uncontrolled hyperglycemia. So it is just an agent to bring down your blood sugar, and very potent one at that. Now, over 100 years, why is insulin so expensive? In fact, initially it was animal insulin. Then they came with the recombinant DNA insulin. And it was thought, see, basically animal insulin, those pancreas extracts and all that, was huge. And they found that the requirement of insulin and demand for insulin worldwide would be so great that you would never be able to supply it by using animal insulin. Recombinant DNA technology came, E. coli was producing insulin phukat mein, but everybody thought that you will have enough insulin and the price would come down. We got enough insulin, but the price went up. It is much easier than getting the animal insulin. So nowadays what we find is that there is a widespread adoption of newer insulin analogs by physicians in the past 2 decades, United States and India. But healthcare providers should also weigh the advantages of insulin analog against their cost and be aware of low-cost insulin alternatives also. Human NPH and regular insulin are less expensive than long-acting and short-acting insulin analogs. I attended this beautiful debate in 2015 in Boston, ADA. The debate was, are the new insulin worthwhile in the management of type 2 diabetes? And for the proponent was Bergenstahl, who said new insulins are worth it. Let's not stop the tide of innovation. There's a new molecule, new innovation, fantastic. That gives you, though there is an increased price tag, but look at the convenience, flexibility of injection timing, avoidance of weight gain, minimal disruption of daily routines. By using newer insulin, these matters can be readily addressed. And he considered there that if the current trend in cost continues, the analog insulins are very expensive even in the US. We should try to reserve expensive insulin for patients who need them the most. And I don't know which. Type 1 diabetics is a different story altogether. Nathan was against the newer insulin, and he said new insulins are not worth it. Nathan suggested a clear distinction between the clinical experience observed in patients with type 1 diabetic and those with type 2 diabetes. He gave 2 clinical examples to highlight his point. First, severe hypoglycemia, a common and serious complication of insulin therapy with type 1 diabetes, is rare with patients with type 2 diabetes. The second point he said is, data presented showed that the frequency of nocturnal hypoglycemia to be 20 times lower in type 2 diabetes than in type 1 diabetes when patients are matched for similar A1C control. Nathan further presented data showing similar glycemic effect between the old and new basal insulin, that is your NPH and glargine or others. Furthermore, the rate of severe hypoglycemia found in studies was exceedingly low and did not warrant concern. So Nathan said, why should the patient with type 2 diabetes pay 3 times the price for insulin glargine? That time there was only glargine. The Detimer and Tresiba and all had not come. Should pay 3 times the price. when NPH is just as effective and the risk of hypoglycemia is rare no matter which basal insulin is used. And Nathan also said, I was there in that meeting, he said, if a type 2 diabetic on insulin has a bedtime snack, his chances of getting a nocturnal hypoglycemia is practically zero. Now, this was Medscape Diabetes Endocrinology commentary by Al Zaid based on this debate. He said one could almost hear Nathan implying that the issues of nocturnal hypoglycemia have been deliberately manipulated to instigate fear and promote certain insulin products. They only exemplify the power of advertising over substance. This was the comment in Medscape. And he further goes on to say, I was swayed by the practical points raised by Nathan. I left the room convinced that new insulin were not worth the money and should not be distributed routinely and across the board for the management of type 2 diabetes. I also believe that the bandwagon for nocturnal hypoglycemia has gone too far and lacks adequate justification in patients with type 2 diabetes. And he further goes on to add, we should not hesitate to prescribe standard insulins or be intimidated into using new analogs without discretion. In some sense, he says, going back to old insulin is going forward in the management of type 2 diabetes because the cost factor is really prohibitive. Analog long-acting insulin cost roughly 5 rupees a unit, 5 to 6 rupees a unit, whereas a human premix costs 85 paisa to 1 rupee per unit. So if somebody is having 50 or 60 units, he's going to spend 10,000 rupees a month on analog, and it works out to about 1,800 rupees on human insulin, which is very important. So you have to think about it. What do the guidelines say on this? Whether you should use analogs or not. This is the ACE guideline of 2023. There it says, when you're using basal, they prefer basal analogs over NPH. It's in that box there. As far as bolus, rapid-acting analogs are preferred over regular insulin. This is the ACE 2023 guideline. This is the ADA 2024 guideline, which leaves the choice to the doctor. He says, add a basal analog or bedtime NPH insulin when you want to use a basal. So the choice is left to the doctor. But the NICE guideline of 2022 says start insulin, offer NPH insulin, maybe injected once or twice daily to meet the need. Consider NPH and short-acting insulin or even pre-mixed biphasic human insulin. And he says you should consider switching to analogs. When? First is those patients who do not reach the target HbA1c because of significant hypoglycemia. Then you switch to analog. Or who experience significant hypoglycemia on NPH insulin irrespective of the level of HbA1c. So if you're getting hypoglycemia, that would be the indication to use an analog basal. Indications for insulin across the board, uncontrolled type 2 diabetes. See, type 1 diabetes is a different ballgame. Personally, I would think analogs are good, but if the cost is an issue, we still have to make do with human insulin. And that is the role for analogs here. Type 1 diabetes, definitely. But when it comes to type 2 diabetes, we have a choice. In hospital management of insulin, hyperglycemia, you need insulin. Perioperative, post-operative, surgery, DK, honk, special population like pregnancy, you need insulin. And there again, human insulin are the preferred ones. But now some of the analogs are also approved. Infection and sepsis test hyperglycemia. So basically, initiation of insulin therapy is recommended to achieve optimal glycemic target, emphasizing the importance of timely intervention to prevent complications associated with uncontrolled hyperglycemia. So basically, if you see insulin, it is an anti-hyperglycemic agent. When you have failed with your OHAs, you still want to get a good glycemic control, insulin is the choice. Various types of insulin analogs, including rapid-acting insulin, intermediate-acting insulin, long-acting insulin, offer diverse options for glycemic control, ensuring flexibility and convenience in dosing requirement regimes for patients with diabetes. So you have a whole horde of insulins which are now available. You have to use the ones which you are most comfortable with. And that comes only with practice and over a period of time. But here again, I am a very patient centric physician. I have always been. And cost is a very important. And I see a lot of my students here and they know it, that I'm very cost conscious because my patient's interest is my primary interest. And that is what drives me. So if he can be controlled with a human insulin, I don't see a need to give him an analog. But if there are special circumstances which warrant the use of an analog, I'll definitely give him an analog. Analogs are beautiful drugs. It's only the cost. If probably the analogs come at the cost of human insulin, I'll give analogs to everybody. Why not? But it's the pocket which is important. So insulin is the remedy primarily for the wise, whether they be patients or doctors. Everyone who knows it requires brains to, everyone knows that it requires brains to live long with diabetes. There's a saying, a diabetic who knows the most lives the longest. But to use insulin successfully requires more than brains. Requires more than brains. Your brain will tell you something, but listen to your heart also. That is where the combination of your brain and heart will give the best outcomes for your patient. Thank you very much, ladies and gentlemen.
Please give a standing ovation to sir.
Thank you.
And I think for ovation, there is no question and answers. Thank you, Manoj, for asking us to chair this very important session of our mentor and guardian, Dr. Vijay Panikar, sir. Thank you, Manoj.
Thank you.
Sir, excellent talk with respect to your journey or insulin and excellent oration.
Thank you very much.
Photograph. Photo.
Good morning, everyone. Now we shall start with the next, uh, the Wonder Woman session, which we are waiting for. So, so uh, I'll first welcome. Over to you, ma'am.
What is it? I know. This one. Huh? Yeah. Uh, our first topic is we are going to talk on metformin in pregnancy, ha ya na. And our first speaker is Dr. Rajiv Chawla. May I invite Dr. Rajiv Chawla, please? Dr. Rajiv Chawla. Dr. Shalini Jaggi from New Delhi, and Dr. Mayura Kale from Aurangabad.
So, good morning. I request everyone to please sit down and let us start with the session. I welcome Dr. Raju Chawla and Dr. Shalini Jaggi for the next session.
Hello. Yeah. Metformin has been used for a long time before. Now, will it be useful in the pregnancy because it is insulin sensitizer or not? There will be a conversation and a debate, not debate, you can say, just a talk, which will be handled by Dr. Lily Rod.
I'm Dr. Mayura.
Dr. Mayura.
Yeah.
Okay.
Yeah. Yes, yes.
Please.
Thank you so much, chairpersons. Good morning, everyone. So actually, we'll be having a conversation and I'm feeling like I'm a Ranveer over here. So, but still, we have been using metformin since last almost 40 years in pregnancy also. And it's a good anti-hyperglycemic agent. It is covering maternal hyperglycemia, but there are controversies because it crosses placenta. So it may cause, though it doesn't cause any congenital anomalies, but it may cause the increased risk of the small for gestational age babies, as well as there may be increased chances of obesity in the offspring in long term. And another thing, there are no international consensus of usage of metformin. So few say use metformin as a first line in JDM, few say you should use insulin. So I hope to get the answer of after this conversation between two of us, all of us, sorry. So coming to the first question to Dr. Chawla, sir. So can you just tell us about the efficacy of metformin in pregnancy?
Good morning. Thanks. Well, metformin still remains one of the very efficacious drug in management of hyperglycemia in pregnancy or GDM per se. The mechanisms of metformin therapy are still not very well understood, although it is one of the most prescribed drug yet in pregnancy, and we have a close to 50 or 60 years of experience of using metformin. Molecular mechanism still remains obscure, but once it comes to efficacy, we know when we are see there are three situations, whether you're handling someone who has a pre-existing type 2 diabetes. Type 1 we'll not touch upon, which is entirely different scenario. Someone who has only GDM, which is coming for the first time, any degree of hyperglycemia in pregnancy getting noticed, maybe in the first trimester or classically in second or third trimester. So in those situations, metformin remains very effective. Although we know that close to 30-40% of patients, they can still be managed on MNT, lifestyle modification. But if that is still not enough to get glycemic control, because targets in pregnancy are extremely stringent, Believe me, it is 90 fasting and 2 hours postprandial should not exceed 120 milligram.
That's true.
So moment after 2 weeks of MNT, we are not able to get that glycemic control. We must ensure the targets are met. First line option conventionally is metformin. In terms of efficacy, you asked, efficacy of metformin is good, but all those patients, those who have uh, exceedingly high degree of hyperglycemia, which in GDM is not very, very common. GDM is primarily a state of insulin resistance, which is coming up in the first trimester. And as pregnancy grows, insulin resistance increases because of counter-regulatory hormones. So then many of those patients, for want of good glycemic control, may be started on insulin.
Thank you. Dr. Shalini, I have now, since Sir said it is efficacious. So if you compare with metformin, do you feel you can use, if you compare with insulin, sorry, do you feel you can use metformin in each and every patient instead of insulin?
Okay, so if you go by the guidelines and recommendations, insulin remains the drug of first choice for pregnancy. So I think any degree of dysglycemia that the patient comes to you with should be offered insulin first if MNT and lifestyle is failing. All said and done, if it is gestational diabetes or if it is a lady with type 2 diabetes who is on insulin but needs higher doses of insulin, there metformin can be added. Certain situations where insulin cannot be prescribed, the DIPSI guidelines very clearly say if there is a problem in insulin availability, if the lady does not have the IQ of actually taking insulin, because insulin is not so simple. Regular self monitoring, injection, changing vials, so all those things, cold chain maintenance, everything is required. So, in situations where insulin is not possible, metformin can be given. So, all said and done, we need to understand any woman with type 2 diabetes can be a good candidate for metformin. The only few contraindications to metformin are fetoplacental insufficiency, preeclampsia, hypertension, IUGR. If it is a high risk pregnancy where the degree of dysglycemia is such that fasting is exceeding 110 or post meals are definitely beyond 140, if it is already a macrosomic baby or you are seeing any of the complications in terms of pregnancies going into polyhydramnios, you are seeing fetal distress, you are seeing IUGR, any of those high risk indicators, you should not delay insulin. The only contraindications to metformin would be GI intolerance if the mother cannot tolerate it. Of course, renal hepatic dysfunction are again contraindications for metformin. And beyond that, IUGR, fetoplacental insufficiency, preeclampsia, hypertension, any of these you should not give metformin. Even if a lady is on metformin and during her antenatal scans you see that the baby is getting small for gestational age, or you are seeing any of these things develop, you should immediately stop metformin. If these are not present, metformin can be continued, but you need to talk about the pros and cons of metformin with the couple and take an informed consent when you are prescribing. Now, the best part is DIPSI guidelines, which are endorsed by the government of India, have cleared metformin use. And so many of our obstetrician friends have been using metformin for so many years that we have lot of data which says there are no congenital anomalies which we are scared of with metformin. So I think metformin can be a good option if insulin is not acceptable to the patient, or if it is a mild degree of dysglycemia or gestational diabetes.
Okay. So, sir, since Dr. Shalini has told so well that we can use it, but still there is in our back of minds it's going on whether I should give it or not. Whether so, what are the safety concerns? So, especially if you are planning to short-term safety concerns, I want to know basically, especially if a woman is planning, especially type 2 diabetes, she's obese and she's planning a baby. So, would you give her metformin? Second thing, whenever a woman comes in the maybe detected at the start of pregnancy, but it might be pre-gestational, but detected maybe in the first 4 or 8 weeks of pregnancy. So would you give metformin here in these populations?
I think these are entirely different situation, different scenarios. First is if woman has PCOD and she's conceiving out of PCOD, probably the safest drug option is metformin. Although ADA or even our own DIPSI guideline, we said that at 12 weeks, moment you detect uh, GDM in the first trimester, 12 or 13 weeks, you should stop metformin because there's no advantage of continuing metformin those who have conceived out of PCOD. But still, most of the gynecologists, they want to continue metformin as long as possible in view of the fact that possibly that might improve miscarriage rate, although that is still not proven with the global evidence. Second scenario, you said someone who gets detected for the first time, if it is 8 to 9 weeks,
Yeah.
we are these days advocating a very, very early screening for detecting GDM or for at least detecting AGI, that is early glucose intolerance in gestation, which could be simply a postprandial sugar more than 110 milligram at 2 hours. There, whether we can use metformin or no, yet that needs to be answered. There are only two studies, both published in Curious. This is originally a concept given by Professor V. Shishai, is mentor to all of us. And he is now talking of primordial prevention. Primordial prevention means you do sugar for the first time at 8 to 9 weeks. If it is more than 110 milligram at 2 hours, immediately MNT must be started. And insulin remains a gold standard, but still there is no evidence across the globe because they think all Caucasian studies talk of developing GDM at 12 to 13 weeks. But in India, we have lot of patients. Amongst us, we have close to 50 patients whom we have seen they are developing GDM at 8 to 9 weeks with HbA1c less than 5.5, and they clearly are exceeding 140 milligram. So there are early GDM happening even at 8 to 9 weeks. So we still feel that they can benefit from metformin. One study is published from in Curious last year, Dr. Sheshai, Dr. Anjalakshi's own data, where they said that if you use metformin, you may prevent actually conversion to GDM in 185 patient. Another study published last week only in Curious, that is Dr. Piki Saxena. I was also part of that trial, where again it was seen that if you give them metformin, it might help in getting good glycemic control. But it is still, we are still fighting with the DGHS, we are fighting with the ICMR and dot people, whether metformin today can be adopted as a option at 8 to 9 weeks, because evidence is still not very, very great. But Dr. Sheshai feels that a drug which helps in conceiving on PCOD, that means it is absolutely safe till 12 weeks. How it can harm someone who has mild degree of hyperglycemia, AGI? So let them be on metformin. I'll still say that as a guidance, insulin remains a gold standard, but these are two evidences which are already published in last 1 year that we have found them safe on metformin as early as used at 8 to 9 weeks. Yes.
Being the devil's advocate, let me bring to your notice a few studies that have happened. Empower trial, Grow trial. These were trials where metformin was given to obese women who did not have type 2 diabetes, with the simple intent of seeing whether metformin given to obese women can prevent gestational diabetes in these women from developing. And both the trials clearly showed that this did not happen. They eventually did go on and develop gestational diabetes. Similarly, in PCOS, also women who do not have dysglycemia, women with PCOS given metformin prior to conception and continued PEDMET study and a follow-up of PEDMET called PREDMET study. Both these studies showed that it did not really prevent conversion to GDM. So GDM did occur despite metformin being on board. And rather, the long-term follow-up of PEDMET was the PREDMET study, where they looked at the BMIs and the Z scores of the children who had been exposed to metformin intrauterine, and they had signals towards obesity. So again, you have evidence swinging both sides. The pendulum swings both sides.
Yes.
The reason for that is the transplacental transfer of metformin that occurs from the mother to the fetus. Now, all the studies that we have, most of them are mouse studies. And in mouse studies, it has been shown that besides the OCTs, the organic cation transfers through which the metformin is passed from mother's body to the placenta and fetus, They have other transporters also, the serotonin transporters, PMAT transposers, and MATE1, MATE2. These are some different transporters that are present in mouse embryos. So the quantum of metformin transfer in mouse embryos is different from the quantum of metformin transfer that occurs in human embryos. So that is why we do not really have too many studies. And they did use, I mean, I just went back and read all this. So in the human fetal embryo cell lines, OCT1, OCT2, and OCT3 are the primary organic cation transporters that are present. The metformin that is transported across that is not really causing potential fetal harm. But in a normoglycemic pregnancy, if metformin is given, some studies have shown in these cell lines also to have an anti-apoptotic effect and an anti-inflammatory effect. So it is still being studied. The word is not out, but a vast amount of experience tells us that metformin is essentially safe when it comes to congenital malformations or teratogenicity. Small signal of small for gestational age, maybe because of these transport that occurs, which is still being studied, and the final word is not out because most of the studies are embryonic studies from mouse embryos. And now that they've found out that the transporters are completely different in human versus mouse, so we need more human studies, I think, to have the final verdict.
I think
So,
just to add on what she very rightly said, there have been three major trials. MIG was comparison of metformin versus insulin, where metformin was found to be absolutely safe in pregnancy, close to 375 patients in each arm. Then was the MITI trial, PREGMET trial, and MIG TOFU trial. At 18 weeks, at 18 months, 24 months, and 8 to 9 years follow-up of all offspring born out of hyperglycemia in pregnancy when mothers are on metformin. All these three trials, major trials, have established that only thing what might happen if mother is on full dose of metformin close to 1.5 to 2 gram, that offspring born will have higher subcutaneous fat, subcapsular fat, biceps or tricep thickness will be on the higher side at 2 years. And these offspring subsequently grow as adolescent. They are the one who are likely to develop uh, maybe obesity, hypertension, and little greater risk for developing type 2 diabetes. These are three trials only where it has been seen that on metformin there is no other problem except that you will have little increase in small for date, and weight of the baby will be on the
Prematurity also.
prematurity, and weight will be on the lower side in at birth, but subsequently they will have a catch up growth and they will be at a greater risk for adolescent obesity versus insulin.
Dr. Manoj has
Manoj
a
wants.
Yeah.
Sure. No, I think thank you for the great conversation. Let me begin by wishing Mayura a very happy birthday and
Oh,
spending the
thank
day
you.
with us here.
birthday.
Right.
Thank you. Thank you.
So, my question to the experts is: are we just being overcautious, Shalini and Sir? You know, when you talk about metformin and all the possible effects that even Shalini spoke about and you spoke about, whether it is uh, the nitty gritties of looking at the shoulder, the arm aspects. How many of or how many researchers in the world have actually done that for use of metformin in type 2 diabetes? Right? Today, we are aware that yes, metformin can lead to B12 deficiency, that rare chance of uh, lactic acidosis. Some people coming in complaining about sarcopenia, weight loss, but yet it is the most used drug. And as much as the argument maybe is still the first line drug. So is there really a concern? Of course, in pregnancy, we don't use a lot of drugs because it's not that they are unsafe, it's just that they have not been studied enough to be safe. So are we getting caught up in that conundrum for all these years and denying our patients maybe not the benefit of metformin, but probably the inconvenience of being forced onto insulin without being really, really aware of that? And I'm sure Dr. Sunil wants to add.
See,
Manoj, you very rightly said, and after the results of the MITI trial, UK drug authorities actually have allowed metformin from pre-conception till delivery. So by all mean,
I wish India would have done that before the UK.
India is
yeah, but
already
at least they have a data from
DIPSI,
UK population.
2023 clearly says that metformin is safe. You may give an option of starting insulin, because that remains a gold standard in terms of safety. But all women, once they are pregnant,
But how
and they
many
are,
of us know that insulin also now FDA has abolished category ABC,
yeah, it
but
is
till it existed in all insulins were category B.
B.
None of them were category A.
Yeah.
And metformin is also category B.
Yes. I feel it's a matter of concern when it comes to what you rightly said about the follow-up trial of PCODs, obesity. They did not show any, and that's why it was a global recommendation from ADA that said that after 12 weeks use of metformin in polycystic ovarian disease, there is no additional benefit for continuation of metformin towards prevention of preeclampsia or prevention of GDM. And now we are talking about 8 to 9 weeks for prevention. So we have to actually be again creating our own data and more publications and more research, what Manoj says, then possibly will be more authentic in selling such things.
Unfortunately, there haven't been many prospective randomized trial of metformin versus, except these earlier evidences came in 2000. And our caution came even from MITI because immediate there were no issues, but once these children, they grew towards 8 years, yeah,
All
finally
trials, I
they have all
think, no
concluded that,
congenital
yeah,
anomalies, no teratogenicity, small signal for prematurity, small signal for small for
small for date,
gestational
yeah.
age, children being followed up. Some studies have shown adiposity, some studies have not shown adiposity. So I think you need to look at the patient in front of you. What is the gestational age of that patient? If she is very close to term, you can put her on metformin and see, and manage if she's maintaining glucose levels. If she is very early pregnancy, already a high risk pregnancy, there obviously you need to add insulin. If she needs high doses of insulin, there also you can add on metformin to take care of the insulin doses. Only contraindications, like I said, was preeclampsia, hypertension, IUGR, small for gestational age. So all those signals, when you see the red signals, please add insulin.
I think-
Otherwise, it's your choice.
I think, yeah, I think per se it is hyperglycemia which does huge amount of damage. As long as we can ensure a fasting 90 and 120 postprandial, even on metformin versus insulin, many patients, one third will require addition of insulin even after metformin for getting good glycemic control.
I have some hypothetical
Yeah.
concept here.
Yeah.
Our population behaves much different than Caucasians.
True.
And we have seen that many of the drugs, we are better responders versus others when it comes to insulin resistance and insulin sensitization. So might as well, metformin is better for our population unless and until we come out with our own data. So maybe that we are better responders. And that's why Piki Saxena's paper and other papers coming out as showing better results versus what we have seen in results coming from Western world.
In fact, I must share with you, we have come out with the International Journal of Diabetes in Developing Countries supplement thematic issue, just published 7 days ago, and we have made a podcast. Dr. Purvi was the lead in that. Me and Dr. Mohan were there. And there we have discussed all these situations. We have discussed uses of metformin, certain studies which are published. We have talked of early GDM. We had one study, me and Dr. Shalini, IDPSC versus DIPSI, diagnose GDM, identical outcomes. So we said that you go only with a single criteria. And recently published guideline DIPSI, Sunil, all of us, we are part of those guidelines writing group, where we clearly said in Indian population, give them an option of starting on insulin, but many patients for want of getting good glycemic control, they don't want to be on insulin, cannot afford, cannot monitor insulin. Metformin remains absolutely safe.
But glycemic targets have to be met. If glycemic targets are not being met, then there is no other option. She has to be on insulin. Bottom line is that.
Yes. So only a few, in short, can you tell about the postpartum usage of metformin? Immediately postpartum.
Immediate postpartum during lactation also metformin does pass in the breast milk, but again the fetal the infants metformin levels are not found to be harmful to the infant at all. It does not cause hypoglycemia in the infant. There is so it is found to be safe even in lactation. So for most of the women with type 2 diabetes, Once they've delivered, during lactation, the mother can take metformin. Of course, if the degree of dysglycemia is high, obviously she needs to be on insulin along with metformin. But for lactation, there is no contraindication to metformin. It does pass the breast milk, but the absorption in the baby is much less and it does not cause any harm to the baby, including any risk of hypoglycemia to the baby. That is very important.
Yes. Yes, thank you very much, Dr. Shalini, Dr. Chawla, sir, Dr. Gupta, sir. So to summarize is that metformin can be used in pregnancy. You can start before planning the pregnancy in women who are having type 2 diabetes to reduce the insulin requirement. In women who are not diabetic but having PCOS or obesity, you can start metformin. It can be continued throughout. We can give metformin in the first trimester, second trimester, third trimester, provided we have to see that there is no IUGR, no lactic acidosis, no uteroplacental insufficiency. Metformin may not be effective in 30 to 40% of women, and here we need to add insulin to see is that all the glycemic target, that is pre-meal of 90 and after meal of 120, 2 hours after meal of 120 is achieved. So thank you,
Perfect.
chairpersons, thank you everyone.
Superb, superb. Wonderful debate. Thank you, sir. Thank you, ma'am.
Any comments?
No, I have a question to Dr. Shalini and Dr. Chawla. So that have you seen loss of appetite per se because of metformin when you're using it? I have seen that in 2 weeks. Yes, in
I
pregnancy.
think it is an anorectic agent. If
Yeah.
you're going on
So,
high doses in pregnancy, we have said that up to 2 gram you can use. At 2 gram,
so
you're likely to have some
So
degree
I
of.
got a call from the obstetrician saying that after you started metformin, the patient's weight is not increasing, and she reported that the fetal weight is not increasing. So
This
patients
is the case where
For-
metformin has to be stopped.
Yeah.
stopped. Yeah. So
There,
that is again another message that
Yeah.
no metformin. If after 2 weeks of metformin you do a repeat ultrasound and you see that
there is,
fetal
yeah,
growth pattern.
must start
Thank you
insulin
so
there.
much, ma'am. Thank you so much.
There you must start insulin.
So, with the
And Dr.
shortage of
Shalini
time,
mentioned earlier.
Thank you.
Thank
Thank you.
let's go ahead with the second topic, the pearls and triumph. Thank you, sir. Thank you, ma'am. After the session? Nee? Okay, 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 okay. So, it's pearls and triumphs of woman physician in our country. And I'll first call Dr. Meena Chabra ma'am and Dr. Lily Rodriguez ma'am on the dais. So, next, they will be in conversation with Dr. Alpana ma'am.
Yeah, welcome Dr. Alpana ma'am. She is listed among the top doctors in Mumbai. She has received the Iconic Woman Leader Award in the diabetes specialty category. She is a well-known metabolic physician and she is in communication with the other two. So I welcome Dr. Alpana Somani ma'am and request to proceed the further discussion.
Thank you very much. And there is a very interesting saying which goes by, it's not easy being a pioneer, but oh, is it fascinating? And I really want to have this, I was really happy getting this topic to speak on, and I have two fascinating ladies with me, Dr. Meena Chabra and Dr. Lily Rodriguez. I don't think either of them require an introduction, but we are definitely going to delve into their minds, seeing how and what their journey as a lady physician has been. The topic today is we are going to be discussing the perils and the triumphs of being a lady physician. So coming to each of you all, I think before we get into this conversation, I would first like to start what is your best memory of being a physician? That is what I would like to start there. Each of you, please.
Yeah. So I think I like to share that way back, almost 26 years back, because I've been in practice for 30 years this year. 26, 27 years back when my daughter was a little girl. So she dropped me to a conference where there were 30 male doctors and I was the only female physician speaking on ACE or ACE inhibitors. So she looked at me, she looked at her father and said, Papa, so many uncles and only my mother.
Oh, super.
And my husband very proudly said, your mother will be able to take care of all 25, 30 of them. Don't worry about that. And I think she was proud of me. And that's what I felt, that when she saw me work hard and be resilient and manage the home front as well as the clinic, I think she learned a lot. So I think that is the triumph of a lady physician, that your children look up to you.
True, absolutely true. And Lily
Yeah,
ma'am?
same here. I am 32 years of experience as a physician, lady physician, and I've traveled from one city to another as a physician, from Pune to Delhi to Bihar, and finally in Hyderabad. And I've seen a lot of, I should say, it's an encouragement all through. And I've really, really enjoyed myself as a lady physician, because we, as women, have many things to look up to. And I think I always felt that we have sixth sense to understand our patients before they even speak. So that is one of the greatest quality that women physicians have. And many patients like to come to us back and, I mean, again and again, because of that quality that we have.
So we have a lot of male doctors sitting here. I can proudly say that we do have a better psychosocial connect with our patients, or probably, which you may disagree, it's individual difference, but I think we do address families and psychological issues more, and our conversation is more family centric, children centric.
True.
So
Which I'm sure touches a chord somewhere with our patient.
may touch a chord.
Yes.
And the patient also feels heard with female physicians. That's the, yeah.
So coming to Meena Chhabra ma'am, I'd like to ask, how do you manage balancing being a mother and a good clinician together? You just mentioned about this memory, but on a day-to-day basis, how do you manage that?
It's been a difficult journey, so I will not call it easy. It's not been easy. But what my message to the younger doctors would be is to seek support. So we must seek support in friends, in family, in-laws. Should not you? My mother-in-law has been my biggest support, because she could look after my child even if I had help. A dadi is a dadi. So my message is seek support. Then work-life balance is important. I didn't achieve it very early, and I regret that. I worked harder than I should. But I can easily say that after 30 years of
True.
practice.
But I totally echo your sentiments that it's such a big deal is being made about, oh, women are superwomen. But I don't think we're superwomen. It's absolutely okay to ask for support and help, as you very rightly said. Dr. Lily ma'am, how comfortable are you around your male patients? Do you feel a difference around male and female patients? Is there any problem there?
Um, there is certainly a difference in the male and female patients. When a female patient walks into my chamber, she and I both are comfortable, and they open up immediately. But a male patient takes a while, and sometimes, if they have, especially as a diabetologist, if they have any sexual problems, they are very, very hesitant, and they would talk indirectly, saying that, I feel very weak.
Yes. True.
They don't want to say it directly.
True.
So we understand that, and we have to pose a direct question.
True.
So that kind of difference I definitely see.
And after understanding and being empathetic to that point, have you ever realized that your patients have gone for a second opinion to a male doctor because they were not very sure about your opinion? Have you ever experienced that?
Yes, I can give you one example actually. I am feeling very embarrassed to say it, but I would like to say it all the same. I was much younger those days, and when I was first practicing in Hyderabad, a patient first time came to me saying that I have problem in my external genitalia. And what is the problem? He says, I have pain. So as a woman, I kept nurse with me, and I opened him up for examination. Asked him to undress, and he laid down. And then I suddenly saw that, he was having an erection. And he wanted me to touch him. So this was a very embarrassing thing for me, and I knew he was faking. So then this was the first time. Then would start coming again and again. Then I had to threaten him.
Yes.
So this has happened.
So I guess, ma'am, what is your
So I think that I had the sometimes you do have patients like that. So an interesting story is that one of my patients stopped seeing me after seeing me for 15 years for diabetes. So I was very saddened that I put him on insulin. His sugars are well controlled. But lo and behold, his wife continued to see him, and so did his parents because they are all diabetic. And later she confessed that he had erectile dysfunction, and he treated you like an elder sister, or so he went to a male physician. So we lose some, we gain some. There may be women, and I can say that. So let me give you an instance. When SGLT2 inhibitors came, actually remember the roundtable meeting, Dr. Shalini, where everyone said Dr. Meena Chabra doesn't talk about hygiene, and that is why she's saying 10 to 12% of her female patients get genital infection, because all international studies said few. And I shouted, and so they said you are argumentative and you should talk about genital hygiene. And now it is clear that in India, uncircumcised men have greater incidence of balanitis and balanoposthitis, and women do have greater incidence of genital infection, whether it's hygiene, the weather, or whether there are some genetic factors. So yes, you are sometimes not taken seriously. It is true by the male physicians. And now I can proudly say that, and then I would answer that when a female diabetes patient develops genital infection, she comes back to me as a female diabetologist, but she may not go back to the male diabetologist and go to a gynae, and they may miss the opportunity of realizing. So yes, we were the ones, the female diabetologists, who made a lot of hue and cry about genital infections. So yes, there is a gender difference there. So it's both ways. If I lose a male patient, suppose he doesn't want to talk to me. Also, sometimes when patients, we tell them that they have unstable angina, and they may go back to a male, But if they go to a cardiologist, I'm happy. But if they go to somebody who's MD, obviously, it's a little, disheartening, but we take it in our stride because we win some, we lose some. So my journey has more or less been good as far.
So I think you already answered the next question I had planned for you was like, do you often, has it ever happened that your male colleagues have made you feel incompetent? So I don't think your colleagues have done that, but sometimes it's a query between the patients. There is an overlap in the question.
Okay, so I'll tell you one again. So something which my male colleagues always said, I'm not saying all, Dr. Chawla is sitting here. I hope he's listening. Sir, please listen to us. It's important. So yeah, thank you so much for your attention. So, okay, so there were male colleagues who said that Dr. Meena Chabra is a dietitian. So that is again, it's stereotyping the female physician who's an MD medicine with several fellowships and diplomas in diabetes. Because I started telling the patient this proudly, yes, I have also studied nutrition. So I think we are better with nutrition and with diets. And that's one thing which bothers this is not a battle between the male and female doctor, but what I'm trying to say is that we had 50% doctors in MBBS, but we'll just see PGs much lesser. I'm talking about my times, now they've changed, and in senior roles. So one is lack of mentorship. A male doctor usually has mentors a male junior doctor, and if he tries to mentor a female, it's a question mark. Why not? So mentorship also. So if you have senior mentors as females, maybe we have more females now who will be doing well. So we need mentorship also. And we need men to mentor females as well. Why not? It's a mentor-mentee relationship and not a man-woman relationship. So why do we, and women look down upon it. So I think women are also responsible
I
for.
think we can take it one step further that as women physicians, we can also make it a point to be unbiased in when we are taking up our mentees. That make sure that the gender of the person whom we plan to mentor is, it does not matter whether it's a male or female, and increase the tribe. If you see someone who is as qualified as the male counterpart, please don't hesitate in taking her up as a mentee. So the next question, ma'am, to you only, Dr. Chabra, is like, have you ever found that you have to sacrifice your working hours to take care of the family?
Yeah, I have, obviously. It's true because It may be different for women, different women. So this is a very personal question because I have a husband who's a neurosurgeon. I do have to do it. But it's not that I had to sacrifice. I did it voluntarily because you love your children, you want them to do well, you love your aging parents and in-laws, and you have to look after them. So gender roles are still defined. And maybe I'm passionate about cooking, so I cook. No one forced me to. So I think breadwinning is the male. That's been traditional. And we are seen as, so yes, I've had comments from families saying that, why can't you shut the clinic? Your husband's working, he's operating. So my work is seen as not breadwinning, but probably cake, cakewalk, or eating cake, or I'm just, so I think there, this gender thing remains. But it's not, I think it's inbuilt in our systems also. I think women are more patriarchal than men are. We don't want them to go to the kitchen. I will tell my husband, no, 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 I'll make tea for you. So I think we've started a program called Boys Should Learn to Cook for our type 1 diabetic patients. And it's really, the message is clear. If we can teach our daughters to swim, to drive, we can also teach our sons to cook. So I think we all should be a part of that drive, whoever has sons, that boys should learn to cook, because cooking is not patriarchy. Cooking is a survival skill. So I'm a part of that patriarchal system where I feel my brother, my husband, my son, I should,
True.
Yeah.
I would like to add one thing coming from the next bunch of female doctors, that I don't think sacrifice is always the right word. I think it's a choice that we make. We can multitask better, and it's always a choice that we are taking. So I feel that that is a very important thing that need, and I think the world has changed. The men today are all working in the kitchen as well as at home, at work. They're side by side with us. So things have changed, but I'm sure there is, the path needs to be treaded on more often than not. Lily ma'am, a question to you. Do you ever, have you ever noticed that male juniors had a difficulty in taking orders from you?
Um, Not to a great extent, but yes, if a male counterpart gives them an order, they would very easily do it and without a question. But when I say it, yes, they have a question, first of all. They would like to argue and then come to then they might do it because I'm very strict.
Yes.
So this kind of a subtle difference I have seen, yes.
So it's good to emphasize your point, even
Yeah.
if it needs to be.
Yeah.
Yeah. The next question for you only, Lily ma'am, would be, how does it feel every time you achieve a new high and you set the bar higher for the females, males, everyone?
Yeah, this is a very good question for me because I'd like to say a few points about my own journey as a leader in our state of Telangana. It started when I stood for an election for chairmanship of Telangana State RSSTI, and my other competitor was a male doctor. It's not a competition between male and a female, but it so happened that I was competing with him, and there were a lot of his fans rather went around canvassing for him indirectly, and they wanted to even take his the people were not voting to take down their phone and vote for them and things like that. So, but I happened to win the election, and I took it on myself and saw that a lot of changes happen in our state, and finally it culminated in the Telangana State RSST, which was held this May, and this was one of its kind for our state.
Wow,
This was
congratulations to you.
upheld by so many people, and I rather, I felt so happy. Not that I became proud, but I was so grateful to myself for having achieved that, and I
Well,
set a goal for the state as such.
and also, probably a lot of female physicians are looking up to you
Yes,
because of that.
definitely.
So
So
this is,
many of them.
yeah, this is what I'm saying. So if we have mentors, so we have her, we have other mentors, we can have younger mentors. Like I have Shalini sitting here, she can be a mentor to all of us. So I think that matters. So you need that mentor, mentee, and we have to hold hands of some of the. But the journey is not simple, and it's an individual journey. It could be more difficult for some people and simpler for others.
So, Dr. Chhabra, what inspired you to pursue the field that you're in? Was the outside environment supportive or not for your choices? And what's your take on it now? Are you happy with that, or
I am a very
you
proud
wonder?
physician and would like to be a physician for the next 7 lives. So I'll tell you why. Because as a physician, you can be a teacher. As a physician, you can still be a fashion model. I can wear what I want to do, even at the age of close to 60. And I can be a counselor. I can talk to my patients. I can have lots of friends. I can have help support groups where people, look up to you. And definitely I can be a mentor to the entire young generation of females who actually can look up to us and say, yes, a female can achieve what she wants to achieve in spite of the difficulties. There will be difficulties. If your child is unwell, you'll have to look after the child. I'm not saying don't do your duties, but as a woman, I feel we can multitask more than men can do. So multitasking is important, but I emphasize self-care is also important. So again, my message is not at the cost of self-care. And you don't have to be apologetic to look good and say, oh, I'm a physician, but I'm still, you know, trying to dress up, trying to go to the parlor. So yes, you don't have to be apologetic, which we were.
Absolutely.
We were supposed to dress up as stereotypes, but I think the mindsets are changing. The younger doctors are now more. And so the problem is that we've brought up empowered daughters. But sadly, as mothers, we have failed to empower our sons, and we need to do that. We have to empower our sons. The patriarchal mindset has to change. Looking after a child is not just a woman's job. A man can also change a nappy. So I think my journey may have had its trials and triumphs, but more or less my positive message is that I'm very triumphant as a physician, and I love being a female physician.
The main thing is not to give up at any time. Just not give up, even if you face, perils many times. Maybe more than a male counterpart, but never to give up.
Yes.
Be positive, strong. This is a message to all the female doctors here.
Also, I feel times are changing. Times are changing. It is not so difficult anymore. At least in the urban populations, we are seeing a lot of, I wouldn't say help. I wouldn't call it as help. There is an increasing amount of equality in the houses at least. And that is going to transpond into your professional field later than never.
One
Definitely.
more thing is that meeting. So, what happens is sometimes you are said that you're not academically oriented when you can't attend late night meetings. So, as a gynecologist, meetings happen between 4 to 6 p.m. But as a physician, most conferences are beyond 9 p.m., the local ones. So, there are certain things we ourselves would like to change. So, it becomes difficult. So, it's like, if you attend the meeting, you come back late, then you are guilty. And if you don't attend the meeting, you are guilty because now your colleagues might say you are not academically up to it. So it's a tightrope, it's a balance. You'll have to strike a balance and you'll have to continuously work towards it. So it's a
So
difficult
we've all
task.
spoken about so much. We are all really happy making these decisions, being a female physician. Current situation that's going on, we can't close our eyes to that. What is your take on the safety of women in their workplace? Not necessarily in terms of what happened, the sad event that happened in Calcutta, but overall. Uh, any take on that? Like, what is your take on safety issues for women in medicine?
Yeah. What I personally think and feel is we as women should first of all learn to protect ourselves uh, and learn to, be present in the moments wherever we are. If we are going for a party, see who is coming there and dress accordingly, appropriately. I do not think we should invite trouble at any time. So that one thing we should look after ourselves. And secondly, be strong and even learn some I don't know what you call that.
Something like for self protection,
self-protection.
self defense. It's always good to be fit. It's always
Yeah.
good to be able to help
Fit,
yourself.
yes. Never give up fitness exercises. Yes, you should do. Even if it's, uh, even if it means 20 minutes or 15 minutes, must do fitness exercise, be it any age, even my age, I do every day. So that gives you mental strength as well as physical stamina, and you can be active the whole day. So protect yourselves. That's what I would like to say. You can
Yeah,
please add.
so I think, Dr. Puri, I'm very grateful to you for taking this up as a topic. So thank you so much, because there are very few forums which would agree to take such a topic. So I'm grateful. And yes, so one interesting anecdote to my three favorite people sitting right on the first bench. A week back, a medical rep came to me, and then he said, "Doctor, please prescribe." I said, "Yes." And he said, "But you're not writing. Please prescribe." It was some combination of pregabalin with nortriptyline. And then he's saying, "Doctor, please write. Dr. Satnam is also writing in Gangaram." So I am supposed to write a drug prescribed by my husband in my clinic. That's the gender bias. And day in and day out, I get messages from pharma guys, "Dear sir, kindly write." And I promptly write, "If you feel all female diabetologists are sirs, then I also strike you out of my list." So I just block him. So yes, hmm? Yes, good. So that is why I think I'm grateful, but this is not about gender. I'm not a feminist. I actually say I'm not a feminist. I strongly believe that gender roles are different. I may be better in nurturing. I may be better at caregiving. And so yes, so they should be complementary. And so I'm not saying we shouldn't do our job. So the message is clear. We shouldn't not cook because you can cook, but you want your husband to cook. If you're passionate about cooking, go ahead. If you don't want to cook, do something else, do that. But pursue a hobby. You must do that. Self-care is important, not drowning yourself in.
Absolutely.
Yeah. So that is
Absolutely.
my message.
So
And a
let's not
happy
put the
woman.
onus onto the men to be saving us.
Yes.
Let's be proactive that we can take care of ourselves. But at the same time, there is an Israeli form of self-defense which is called as Krav Maga, where there's a lot of martial arts involved in that. But even in that field, they always say, try and prevent a disaster. Don't be foolhardy and try and attack a person back. Make sure that you are keeping yourself safe. So I think we can apply the same thing here also, that at every point in time, if you feel that you're in an unsafe situation, please procure safety for yourself rather than trying to physically fight with a person, because that is not possible. So that is one thing which we need to keep in mind. And from both the panelists, this is a question which I would like both of you all to answer. What are the best tips you can give to an income medical female doctor? Like what is the take-home message for them?
I would like, I teach in a medical college, and I always see in that particular medical college, the girls are more than outnumber the boys. And I always encourage them to learn the subject in depth. So if you, knowledge is power for a woman. So if a woman studies well and goes into the depth of a subject, definitely she will, look after herself, come what may, no matter which situation she faces in her future. So that is the, from then, from undergrad situation, she learns to protect herself for future.
True.
So even now, it's never too late. So at least 1 hour a day, we should learn. We should read about the upcoming subjects and the recent advances and all that is happening around us. Otherwise, we'll lag behind. So that is what I'd like to say.
Thank you, ma'am. Dr. Chabra.
So my message to the young doctors is that yes, it's a tightrope, but you should actually be ready for the challenge.
Yeah.
And yes, there's no shortcut to success. You have to work hard. You have to be resilient. You have to attain knowledge, and you have to read a lot. And other than that, self-care is important. Your personal space, happiness is important, and looking after your family and friends is important. So seek support is my mantra. What is a conference? It's seeking support in our friends. When you meet so many people, you talk to them, and that's when you know how beautiful people are, how wonderful everybody is, and they bring something new to the table.
Yeah.
So Puri may bring something else to the table, Dr. Lily may bring something else, and Shalini may bring something else. So I think that's when your plate becomes richer, when you get so many people talking. So I think we should seek support. That's my be among people, seek support. And remember, everybody has good in them. So everybody is a good human being. So I end by telling my female doctors, the world is beautiful. Take one step at a time. But as Dr. Lily said, nothing short of working hard. Please be sincere. If you work hard, there is nothing which can stop you from succeeding. You
Please
have
don't
to
play
work
the
hard.
woman
You
card
have
and
to.
expect that you will be promoted just because you're a female. Work hard and get that.
Reverse gender
Yes.
bias that, you know, you want.
In fact, we are in the beautiful time where we have options. We can choose what to do, what not to do. The patriarchal society is as stubborn with men as with women. Nobody asks men, do you want to be a breadwinner? Right. In today's time, as female physicians, as nurturers by nature, we are living the best time possible as a female physician, especially in the caring field of us. And we are celebrating ourselves. In conferences, we come as glamorous, we are treated as a glamorous quotient, but unfortunately, some opposite gender takes it as a glamour quotient, but we are celebrating being women.
But
That's the
I
best
don't
part.
think this thing should end as a man bashing
No, no,
thing.
no, no, no.
We are
No,
glamorous.
very few,
Accept it and own
very few,
it.
very few. There are complaints that, you know, why should female dress up so much in conference? I mean, we are celebrating anyways.
I'm sure
Everywhere.
all the men also take care. They wear suits and they're coming well
we are
dressed.
giving them a target. Ke, okay, like, you know, हमको भी, like, you know.
But I feel that if you make yourself strong, have little patience and confidence in you, you will definitely be a successful woman.
Absolutely.
Yes.
So thank you very much on that very interesting note. I'd like to close this session. It was really lovely talking. Yeah, please, please.
This is the example. She's not looking at me.
No, 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 it's not an example.
I'm-
I had the chair people telling me that we need to close the meeting.
Yeah, but that 2 minutes won't make much
Excuse me,
difference.
ma'am, we have only 2 to 3 minutes to go. We are already.
I'll finish in 1 minute, madam. I'm Dr. Ganpat Sawant. I'm a gynecologist. I'm a president of IMA NBS branch Ghatkopar. We had one conference last 15 days back which showed Association of Medical Women of India. There the same topic was discussed. And the summary is something like this. Yes, females are much better as far as the patient's outcome is concerned. The readmission to the hospital is less amount of medications are required. And some of you said very nicely, they can connect to the family very nicely. One aspect. But second, growth of the female concerned in surgical branches is not so good because of so many things which we cannot discuss just now. But coming to the support to the female practitioners, in fact, some of the female mentors are responsible not bringing them up. And that is why it's so important. So when you reach to these positions, it's because of your hard work. So, and today's generation is such that they don't want to work the way you have worked.
True.
So it's the mentorship, it's so important, especially from the female who have reached the top.
Yes.
And that's why this is the what I thought I'll make a comment. I was standing for a long time.
I agree,
But thank you very
100%.
much for giving the opportunity.
Just one
Thank you,
line
much.
to end up.
And
that
all
I-
male experts, the all female should look beautiful.
That
But we
mortality
become
was less
difficult, they start
with
doubting us.
female physicians.
Thank you.
So mortality, there was a data from US that mortality was statistically different when female physicians treated the patient vis-a-vis male patients. Again, it could probably be because they were more, they gave more time. So they give more time to the patient. And so there is data to support that you can be a good physician even if you are a female. Thank you so much.
Thank you, Dr. Alpana.
Thank you, everyone.
Thank you, Lily,
Thank you so much. It was a
Dr. X.
wonderful
Yeah.
session. Thank you so
Thank you.
much. Let's have a group photograph. Chawla sir, Rajiv Chawla sir, please come on dais. Yeah. Shalini ma'am.
to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. How it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. How it feels.
Hello, everyone. Good afternoon. I know everyone wants to get on with the session, and in the interest of time, so would you please introduce our first speaker for this session?
Requesting everybody to please take your seat. Before I start my next, before I introduce the next speaker, let me inform you one very important thing. Just now, the chairperson, Dr. Shobha Ahuja, whether all of you are aware or not, she has been elected unopposed as Dean of IMS CGP HQ for the year 24-25. Please give her a big round of applause. Thank you. We are starting the liver symposium, and the first speaker is Dr. Bijoy Patni. Where is he? Yeah. He is HOD Diabetes Wellness Clinic, Kolkata, founder of Diabetic Research and Welfare Association, scientific chairperson for 10th Annual Conference DRWA 2023, a regular speaker and faculty at various local and national conferences. He has been awarded numerous awards, including Fellowship of Indian Society of Hypertension, Fellowship of American College of Physicians, Fellowship of Diabetes. He is member and Executive Advisory Committee, ACP India Chapter, ISH, CCDSI, DRWA, participated in numerous studies, contributed numerous articles and chapters in journals of national and international repute, and life member of various professional bodies. With this brief introduction, may I request Dr. Bijoy Patni to talk on liver as a target for preventing diabetes. Please, Dr. Patni.
Good afternoon, all, and thank you, Chairperson, for a kind introduction.
At the outset, I'd like to thank Dr. Manoj Chawla and Dr. Purvi Chawla for inviting me on this liver symposium. And the task given to me is liver as a target for prevention of diabetes. If you are all aware of the fact that last 3, 4, 5 ADAs which we have attended, probably the focus has been on anti-obesity drugs, right? So basically what we need to understand is prevention is the key. And prevention can definitely bring down the burden of the metabolic syndrome or the epidemic of metabolic syndrome which we are facing. So diabetes affects over 463 million people worldwide, and the number expected to increase. What is more important is we need to innovate approaches in diabetes prevention in order to mitigate the growing burden on healthcare as well as the economic infrastructure. So the targeting the liver can be a preventive strategy which offers a promising avenue in order to cut down on this diabetic epidemic. The flow of my program will be like this, my talk. And I've cut down almost all the studies which I'm planning to show because of it being the last symposium. And I wanted to cut down on the time as well. So let's understand one thing, that type 2 diabetes is the most common form. Every one of us agree. And prevention is particularly important for type 2 diabetes. And it can often be delayed or prevented through lifestyle modification. A lot of trials has gone into. We do talk about diabetic remission now, and the direct trial has given us some input or some insight into prevention as well as remission. Now, what could be the role of the liver in the metabolism? It definitely plays a central role in glucose metabolism, regulating the blood glucose levels, process like the various processes like gluconeogenesis and glycogenesis. So it is also responsible for storing excess glucose as glycogen and is released as and when it is required. So if you have an impaired liver function, that will definitely lead to dysregulation of the blood glucose, and that will impair the glucose homeostasis, thereby contributing to the development of diabetes. Now, which is a major liver disease which we are concerned about? We are not going to talk about all the chronic liver disease, but what is more important in today's world is non-alcoholic fatty liver. I think Dr. Pratap Jetwani, thereafter Dr. Panikar sir, all has emphasized on this particular aspect. And this is increasingly becoming a precursor for type 2 diabetes. It does plays an important role. We are already aware of it, and we need to prevent the development of NAFLD as such in order to cut down on the metabolic syndrome, which probably has grown out of proportion. Now, MAFLD or NASLD is the most common liver disease, affecting about 25% of global population. And studies have shown that individuals with NAFLD will be having about 2 to 5 times more risk of developing type 2 diabetes compared to those without NAFLD. So if you look, 75% of the patients with type 2 diabetes have concurrent NAFLD. So it's a bidirectional relationship, you can say, between liver and diabetes. And the interplay is always a little bit of confusion, but definitely we have been able to identify the pathogenesis which can lead liver dysfunction into development of type 2 diabetes. So I have made it a little in this form so that you can understand it rather than showing you all the studies and all the stuff. So what is important? Now we have understood NAFLD is the key player in type 2 diabetes, and NAFLD is the main driver of insulin resistance. So if you can really understand that the insulin resistance is the crux of all the problems, and that is the problem which can lead to lipotoxicity as well as glucose toxicity, which ultimately culminate into type 2 diabetes or beta cell dysfunction as well. So any dysfunction in the liver will definitely trigger some kind of inflammation and then can impair the insulin signaling pathway, which is very important for insulin secretion. Now, this NAFLD can disrupt glucose production and lipid metabolism, and the consequence of hyperglycemia and dyslipidemia, which ultimately is the risk factor for type 2 diabetes. Now, you are aware of the fact any dysfunction in the liver will lead to an oxidative stress along with the pro-inflammatory milieu. Now, both of them, the inflammation and the oxidative stress, will be impacting again the insulin signaling. And if you have a deranged insulin signaling, you will be having an issue with the insulin secretion, ultimately, and insulin resistance. There is again lipid-induced insulin resistance. Even from the diet, we can get the diacylglycerol, or you can get a conversion of triglycerides, which come from free fatty acids, which are stored. And there, accumulation can lead again to a defective insulin signaling. So basically, if all the processes lead to defective insulin signaling, that will have insulin resistance per se developing, and that will be the crucial factor which will lead the progression of NFLD into type 2 diabetes. And then you can have a paradoxical increase in hepatic lipogenesis by hyperglycemia, which will further increase the fat accumulation. So what we have understood from this is basically it is a fat accumulation or increased free fatty acid in the liver, which will ultimately lead to liver dysfunction. That will definitely have a different lipid metabolism, and that will ultimately lead to insulin resistance, which again will be supported by the factors which are increasing the inflammatory pathways and the oxidative stress, leading to more insulin resistance and ultimately culminating into progression to type 2 diabetes. Now let's look at the molecular mechanism of hepatic insulin resistance, because that happens to be the major factor which can ultimately lead to the hepatic liver dysfunction. So you have a lipid-induced insulin resistance, as I suggested, the free fatty acids, which get converted into diacylglycerol, which can impair the insulin pathways. Then they have a chronic inflammation going on. These inflammatory mediators will further disrupt the insulin signaling. And then you have the elevated level of branch change amino acids, which again are leading to the insulin resistance. So these again will be making it difficult for the glucose disposal in the skeletal muscles, aggravating further the hyperglycemia. And then you have these altered liver-derived molecules like fibroblast growth factors and the fattin A, which can exacerbate the insulin resistance. So the focus nowadays also on these liver-derived molecules, and they may be the targeted intervention for bringing down the liver dysfunction. So these are two areas, new areas where probably some studies are still going on. So there will be increased inflammation. The inflammation, the keyword, along with oxidation stress, which can definitely increase the insulin resistance. Now, this has been shown in this particular slide as well. The same thing, you have the adipose tissue insulin resistance, and what you have is increased lipolysis, increased free fatty acid secretions. Ultimately, that will have also decreased anti-inflammatory molecules and increase in the pro-inflammatory molecules, conversion of M1 macrophage to M2 macrophage, M2 to M1 macrophage, and ultimately leading to a milieu which is more inflammatory, and that will lead to increased insulin resistance both at the liver and muscles. So activation of pro-inflammatory pathways occurs, which again increases the insulin resistance. Same thing has been depicted here in a different way. Basically, what happens is you have a free fatty acid overload, you have high triglyceride formations, and along with that, it goes into increased diglyceride increase, activation of the kinases, PKC and JNK, which will again have an impact on the insulin signaling pathway, and that will again lead to IRS and IRC2 phosphorylation impairment, which will have an impact on the glycogen synthase impairment that will lead to increase less of glycogen formation, increase in glucose formation. And then because there is an insulin signaling pathway block, you will have less of insulin secretion as well. So all these ultimately will lead to increased progression to type 2 diabetes. Same thing, these are the factors which can lead to increased lipoprotein toxicity, and the other group can lead to increased glucotoxicity. all will ultimately increase the insulin resistance and the beta cell dysfunctions. So the consequences obviously will be reduced glycogen synthesis, increased gluconeogenesis, impaired glucose uptake, and increased lipolysis. So if we have understood the pathogenesis that this liver dysfunction can ultimately culminate into type 2 diabetes, then you should have a motto, single motto of screening and early detection of liver dysfunction. That's very important. So liver dysfunction in a individual who is prone to develop into metabolic syndrome. So regular screening for liver health is essential for early detection of NFLD and prevention of diabetes. Liver function test, as you are all aware of the fact that they can identify liver dysfunction, but not necessarily. You might have to understand we have recent tools like FIFO score, which you can use that and understand whether there is a liver fibrosis or liver kind of steatosis is there or not. And then you have the imaging techniques and you have the biomarkers like cytokeratin, fibroblast growth factors, etc., which can be a potential non-invasive tools to identify or diagnose NFLD at an earlier stage. Along with that, genetic factors also play an important significant role in determines on individual susceptibility to liver dysfunction. So that has to be kept in mind as well, because genome-wide association studies have identified several genetic variants associated with increased risk of NFLD and its progression to more severe liver disease. So this can again can lead to some kind of precision medicine, which can help us to understand the individual who is most susceptible to liver dysfunction. So if once you have identified them, once you have screened them, then obviously you have to take some preventive measures so that you can prevent liver disease or at least prevent the progression of the liver dysfunction which can occur in the patient. So a healthy diet and obviously a regular physical activity that will definitely help the hepatic liver fat and overall metabolic health. Now there are lots of studies, the smaller studies, etc., which are innumerable studies, which I'm not going to go into it, but there are various studies which have definitely shown that it ultimately improves the overall metabolic health. So maintaining a healthy diet, weight or losing excess weight is crucial for improving the insulin sensitivity, as well as the reducing the risk of NFLD and its consequences. Now, this is what I have to focus on, the patient education. Now, how many of us are really incorporating that in our regular kind of clinics? Now, educating patients about the link between liver health and diabetes risk is crucial for promoting preventive measures and early intervention. Now, even if the patient has come for some other illness, now just to educate them that liver becomes so very important, and liver health becomes so very important in order to prevent the metabolic syndrome, it is extremely important that we need to educate them. The healthcare providers should emphasize the importance of regular screening for liver disease and adoption of healthy lifestyle measures. Patient-centered educational material should be given. We should be very conducive to the fact that the patient's socioeconomic status, the literacy, etc., to be considered, and then after educate that individual. So the prevention measures also there pharmacologically, and there are certain medication like GLP-1 receptor agonist and SGLT2 inhibitors, not from diabetic point of view, but from the liver point of view, have shown promising results in improving liver health and reducing diabetes risk. There are now ongoing clinical trials investigating the use of novel therapies, particularly the FXR agonist and the ASK1 inhibitors for treatment of NFLD and prevention of diabetes. Supplements like vitamin E and pioglitazone needs more research. Medications such as metformin and pepper agonist have shown promise, and we have a molecule, saroglitazole, which probably has a good impact on the liver as well. Emerging therapies targeting the inflammation and lipid metabolism are under investigations. So agents which are targeting the TNF-alpha, interleukin 1 beta and interleukin 6 has been studied. CXCR2 antagonists are also a novel approach. So these are the emerging technologies or the therapies which probably will help us to manage the liver health. And these are the various therapeutic approaches in NFL meds. So the emerging research is all around these newer molecules. So anti-inflammatory molecule is very important. There is another ongoing research which is exploring the role of gut microbiome This probably has gained lot of importance, and this is being looked about. Dr. Roopjyoti Talukdar in some other group might be speaking on this particular molecule, and will be addressing the issues of gut microbiome modulation and the use of probiotics in maintaining and improving liver health. But this is also important public health implication. Now, targeting liver health for diabetes prevention has significant public health implication as a potential to reduce the overall burden of diabetes and other metabolic diseases. Improved liver health can lead to better glycemic controls and its other complications. And implementing population level intervention focused on promoting healthy lifestyles has to be undertaken by each one of us along with the society at large. But still their challenges do remain, and the challenges most important is lack of awareness, not only among the society at large, but also among the healthcare professionals that a liver disease, liver health is so very important. And then limited access to specialized diagnostic tools is a challenge. Adherence to the long-term lipid lifestyle medications or management, this is the most important. So basically, a lot of counseling, a lot of education need to go into in order to make the patient aware or the society at large be aware of the long-term benefit of lifestyle modification for life. Then overcoming this challenge will require a concerted effort to increase the education, improve access to diagnostic tools, and develop the innovative strategies to support patients in adopting and maintaining the healthy behaviors. So the future direction always remain that we have a better education,
Can we wind up,
better
doctor?
healthcare, yeah, better, just one slide. Better healthcare approach to society as large. So always integrating the liver health assessment into routine diabetes screening and management will be very, very important tool in order to address this particular problem. So to conclude, the liver plays a crucial role in glucose metabolism and insulin sensitivity, making it the prime target for preventing diabetes. By optimizing the liver function, we can definitely enhance these processes and reduce the risk of developing any chronic disease, particularly metabolic disease. Early detection and targeted treatment of NAFLD or liver disease could prevent the development of type 2 diabetes, and definitely future research focusing on liver-specific target, liver-specific therapies will be able to address most of the concern of preventing diabetes. Thank you.
Thank you, Dr. Patni, for a lucid presentation. Because of lack of time, we are not taking up the questions. May I request Dr. Ishita to please introduce the next speaker, please?
The next speaker is our very esteemed Dr. Sunil Gupta from Nagpur. He literally needs no introduction, and he has been a very respected member of the community. And of course, he's also been the National RSSDI ECHQ member with obviously multiple accolades under his belt. Over to you, sir.
Thank you. Thank you very much. Yeah. So good morning, everyone. And I am the last but one batsman here in the before the valedictory program. And still we have quite a good number of people in the hall. Thank you very much for being with us. My today's talk is a little non-traditional. I'm known for pregnancy diabetes. So I'm now going, I was told by Dr. Patni, they have been elevated now from down to now you're going little up to liver now. So this is one of the very, I feel it's my honor that I'm going to talk on the guidelines which are officially published today, September 2024. And this has been my honor, and thank you very much, Purvi and Manoj, to speak on this particular topic. EASL, that is European Liver Organization, Obesity and Diabetes Organization Guidelines for Metabolic Dysfunction Associated Steatotic Liver Disease, MASLD. And thank you, DRS, for this. Don't have any conflict of interest. So this is being a joint effort of 3 organizations, which was published in Journal of Hepatology, and I'll be very focusing only on clinical carry-home messages for all of us as a clinician when it comes to liver evaluation. So how these guidelines have been formed is a Delphi process by the international 46-member panel, which include clinician, patients, stakeholders, and those who are working in MASLD. And along with the governing board members of European Association for Study of Liver Disease, European Association of Study of Diabetes and Obesity, all of them joined together and they have come to the consensus with at least more than 75% agreement. And whenever you try to understand the guidelines or consensus, you should try to understand the importance of the words, the recommendation, strong recommendation, weak recommendation. What is the level of evidence? When we talk about strong recommendation, that means it should be done, it must be done, it shall be done, should be done. That's what we say. When we say weak recommendation, that it can be done, it may be done. That's what is the Delphi protocol, and then only they come out with the recommendations. When it comes to level of evidence, if you have one or two level of evidence, you presume that you have good randomized control trial on the subject, and whatever experts are advising have a basis of some RCTs or have a basis of some good clinical good review articles or the good meta-analysis, and which is very authentic. So when it comes to level 1 and 2 evidence, when it comes to 3 and 4, that means they don't have any randomized trial, or even if they're very weak and they don't have any strong kind of meta-analysis, and maybe there's case studies and experiences, and of course 5 is expert opinion. So whenever you get a level 2 or level 1 evidence, you can blindly follow that. When it's 3 and 4 evidence, then you say that possibly some more research is required. And when it comes to 5, it's an expert opinion, but it is consensus. So when I talk about liver here today on this MAFLD, most of the evidences are of level 3. That means there's still a lot of research to be done, especially in our population. So metabolic dysfunction associated steatotic liver disease. All of us now are very, routinely we are aware of only NAFLD. We say NASH. But now you are newer terminology because of the objection taken by some people that why alcohol should be made, should go into disrepute. And that's why now they call it metabolic dysfunction associated steatotic liver disease, MASLD. Become the most common disorder. Prevalence is high, as high as 30 to 60%. Is tightly linked with type 2 diabetes, obesity, and cardiometabolic risk factors. Is associated with increased risk of cardiovascular events, CKD, hepatic and extra hepatic malignancies, liver-related outcomes, especially liver failure, and hepatocellular carcinoma. So these are the concerns. Earlier it was called as NAFLD, and now we call it as SLD. And it is again divided into two forms. So you have MAFLD, that is isolated liver steatosis, as well as those. And the second part is you have steatosis, but you also have fibrosis and cirrhosis, and there could be even MASH, which is like NASH. It is characterized by histological feature of hepatocellular ballooning and lobular inflammation. So you have fatty liver and you have fibrosis at two different stages here. Now, if you have these you already have a patient coming to with sonography report of fatty liver or liver enzyme little raised, but you don't have any other risk factor, that will be isolated liver steatosis. But if you have additional at least one cardiometabolic risk factor, that's what is called as MAFLD, metabolic dysfunction associated liver disease. So what are those risk factors? Very simple. It's exactly like metabolic syndrome. You have obesity or central obesity. I don't want to go into detail of it. Central obesity more than 90 in men, more than 80 in female, or BMI in our population more than 23. Dysglycemia, pre-diabetes, diabetes, both of them, and hypertriglyceridemia more than 150, low HDL or blood pressure more than 130/85, any one of them. And practically, believe me, every person almost, if type 2 diabetes, 70 to 80% is going to have this, because 84% of our people in India have low HDL. When you keep a cutoff of 55 and 45 in female and male, then practically every one of us have low HDL. So one risk factor is already there. So what is a flow chart which has been proposed by this lines? You have a patient coming to with steatotic liver disease. You see the presence of one of the metabolic risk factor. You presume it is yes. If it is yes, I don't know whether I'll be able to use this. Yes. So you say yes, then you take the history of alcoholism. If she is taking more than 20 or he is taking more than 30 grams, then you say that it is, then you have to further go ahead with the history. If it is not there, there is no history of alcoholism, or it is less than that, then you will call it as MASLD. Then if you have associated inflammation and fibrosis suspected, or if your fibroscan is showing F3, F4, then you call it as MASH, that is metabolic dysfunction associated steatohepatitis. MASH is severe condition versus more severe condition versus MASLD. Now, this is very important. This is new thing which is coming now. So if you have a yes here, you again have to see whether it's more than 50 gram in women per day or more than 60 gram per day in men. Then you call it as alcohol related liver disease, or ALD. But if it is less, 20 to 50 and 30 to 60, it is met ALD. That means metabolic as well as alcoholic. And if they don't have anything here, no risk factor, then you have to look for the cryptogenic or the drug induced or other causes. So this is a new category requiring further characterization termed MET ALD, which describes those of MASLD who consume greater amount of alcohol, 20 to 50 gram per day for female, 30 to 60 gram for male, but do not meet the criteria of ALD. Notably, the history of alcohol consumption is an important factor, as in current drinking pattern may not necessarily reflect the previous drinking habits. Importantly, despite sharing the same prevalence, cardiometabolic risk to MET LAD is associated with higher risk of all-cause mortality, and also it's a poorer prognosis. So don't underestimate this particular group, and many of us will get disappointed if you are being classified as MET ALD. So individual with steatosis but without cardiometabolic risk, also known maybe causes possible MASLD, is a new terminology. So then what is this 30 gram of alcohol? 30 gram for men, 20 gram for female. So 30 gram of alcohol is considered as a moderate amount of alcohol intake, which is per day, which is almost equivalent to 24 ounces or 720 ml of regular beer, or 300 ml of table wine, or 60 ml of spirit. That's what is moderate drinking. We say 30 gram. Now, we can have other causes also. Those who don't have any etiology, then you can have hepatitis C, drug-induced lipodystrophy, pregnancy-associated celiac disease, and many more. So I have divided into 20 questions, which I'll just try to rush up. Definition, prevalence, and natural course. Is the presence of cirrhotic liver disease in general population as an important factor in identifying the individual? So should we go for general screening of this disease in everyone? General population screening, panel says, is not advised by the panel. Second question is, which risk factors had a greater importance? History of hepatic disease, including for hepatocellular carcinoma. So which people should be at high risk of having SCC? So those with type 2 diabetes, obesity, age more than 50 years, postmenopausal women, multiple cardiometabolic risk factor rather than one, are more prone to have SCC. Does any alcohol consumption in adult with non-cirrhotic or cirrhotic MASLD have an adverse effect? So it has been said that presuming that beneficial health effect of moderate alcoholism is inconsistent across the studies, and evidences does not support a protective effect, one peg a day keeps a heart attack away, may not remain true after this recommendation. The protective in light of moderate amount of alcohol, particularly in individuals who have cardiometabolic risk factor. So you should not advocate that. Does any alcohol consumption in adult with MSLD have any natural course, will affect the natural course of the disease? Yes, individuals with SLD, particularly those who are on moderate or high dose intake, should be discouraged, and those who already have fibrosis, it should be completely stopped. In general population, high risk group, can non-pharmacological measures prevent MSLD? Yes, it has been recommended that we can go for exercise and diet control, which will be helpful. I'm not actually taking those slides in the discussion. Should a policy of screening MSLD or a fibrotic disease in primary care physicians or at a primary care level? It has been advocated that the diagnosis of fibrosis and subsequent appropriate management is important when the stage is F2 or F3 versus F3, F4. And that is why we should screen the population even at primary care level. Adult population selective non-invasive scores like FIB score, is this good or we should go for the biopsy. So it has been recommended that all these scores like FIB score, I'll tell you what FIB score is, should be done routinely, and they can detect many population. This FIB score is simple. You have to have SGPT and SGLT reports along with the platelet count. You can just put it in the formula. And if your FIB score is less than 1.3, it's normal. You have to go for annual screening. If it's between 1.3 to 2.6, you have to go for the preventive measures very, very aggressively. If it is more than 2.6, then you should be referring it to the hepatologist. Adults should not, what about the non-invasive scores, circulating biomarkers, liver stiffness? So it has been said that the derived scores and elastography should be used to exclude advanced fibrosis, while elastography is better suited to predict advanced fibrosis. Now, is it that in adult with MSLD, sequential assessment of the non-invasive such methods of fibrosis may be of use for, and it has been recommended that those who are being detected in such, those who are being put on the medicine, they should be followed for. Now, do we need to go for genetic study? Then those who have positive family history, yes, we can go for it. Now, is the adult should be those who are diagnosed for NFLD? Should we assess them for the cardiovascular disease? Yes, we should be aggressively going for it. In adult with non-cirrhotic MASH or NASLD, is the early detection of hepatocellular carcinoma should be done in all of them. Less than F3, one need not do it, but for F3 and F4, one should certainly go for assessment of SCC and screening of FCC. What are the factors which will detect the high risk of HCC? Long duration of diabetes, older age, FIB score more than 3.5, and if you have a liver stiffness measurement more than 10 kilopascal, and there is increasing LSM score, and those are smokers. Now, which of the following drugs, I'll just skip this associated with histopathological, I'll go for lifestyle modification. So lifestyle modification, if you reduce the weight by more than 5%, you'll be able to reduce steatosis reduction. 7 to 10% weight loss will be helpful for even fibrosis reduction, and consider incretin based like GLP-1 analog and bariatric surgery. Recommendation for diet control, exercise should be 150 minutes per day, and diet control should be followed. Smoking alcohol to be avoided. And I feel I only have 48 seconds now. So I'll go for the drugs. MASLD, because we are all interested in physical activity. I told you this is about the histopathology should be done or not. Glucose lowering therapy. So you have one drug which is mesmetrione, which has been actually approved by the US FDA. But in we have only GLP-1 analog, metformin, statin for dyslipidemia, and bariatric surgery and GLP-1 analog for obesity. We should be focusing all these risk factors. In adult with MASH, glucose lowering recommendation, GLP-1 analog cannot currently be recommended as a MASH targeted therapy. We still have data coming up, but MASH targeted therapy, no. But weight reduction and glucose lowering efficacy, yes. GLP-1 are safe to use in MASH, except including even compensated cirrhosis. So any case of cirrhosis, any stage of liver disease, you can use GLP-1 analog. Pioglitazone safe to use in adult with non-cirrhotic MASH, but cannot be recommended again as MASH targeted therapy. Insufficient evidence even for SGLT2 inhibitors, metformin, or vitamin E when it comes to MASH targeted therapy. Surgical, yes, we can use bariatric surgery, can help you. End-stage renal disease, you have to have the little limitation. I feel this is my last but one. In adult with MASH cirrhosis, how should pharmacological intervention for diabetes and lipid and CV prevention be adopted? So metformin can be used except in the badly decompensated cirrhosis. Metformin can be used. In those cases, sulfonylurea should be avoided in hepatic decompensation. GLP-1 analog can be used. SGLT2 can be used. Statin can be used in these patients. I feel this is my last slides. So from this recommendation, at least there is much more clarity which drug should be focused. And let me share with you, most of the clinical trials, whether it is semaglutide, whether it's tirzepatide, whether it is SGLT2 inhibitors, have been conducted and have shown the benefits when the fibrosis of liver is up to 3F3 and not at F4. Even the inclusion criteria has excluded all F4 in the GLP-1 trials. And that is why one should try to detect these cases much early so that, and we have lost quite a good number of close people around us who are non-alcoholic, had fatty liver, landed up with SCC, and have really uh, we lost them. So and this is what I'm telling in my own personal practice. So one should now be very, very aggressive. I'm really thankful for the organizers for giving me this talk, that I could go through which is to be screened, when to screen, which drugs are focused, and that's a very strong message for all of us. Thank you very much for patience listening.
Thank you, Dr. Gupta. Before we talk of next presentation, may we have a group photograph with Dr. Deshmane also joining, because Dr. Gupta wants to leave if I am not wrong.
I was happy that I was not there here yesterday evening. Sir, if you have F2 or even if you have F2, F3 fibrosis, I will avoid it. Of course, F4, 100% to be avoided. Sir, that data is not there. This is about daily consumption.
So metformin, pioglitazone, and saraglitazone. Can we use it in combination?
Pioglitazone and?
Metformin, pioglitazone, and saraglitazone. Can we use it?
Saroglitazar, we don't have this recommendation, does not include saroglitazar. So that's why I not spoke on that. But there are good data available. Their phase 3 trial, even in US, has been approved for it. The pioglitazone dose is very, very high, 45 milligram. So there's only one data which has used 30 milligram. All of us are using only 15 milligram. So we're not sure how much it is going to work. But certainly our approach should be early detection and targeting the therapy on those lines. So whatever benefit we can give, vitamin E, not much benefit. Gastroenterologists, they are writing. I feel no one of us are writing. So pioglitazone, metformin, SGLT2 inhibitors, GLP-1 analog should be our
So obicolic acid, some acid is there, something. Something.
No.
Can we have the questions in the end, please? We are already running short of
Sir,
time.
because I was leaving, that's why they are asking. So my question. Yeah. Thank you very much. Thank you.
Without much further ado, thank you for that, sir. I'd like to introduce our next speaker, Dr. Rajesh Deshmane, who's a diabetologist prominent from Kolhapur. And of course, he's one of our favorite speakers. And over to you, sir.
Thank you. Thank you, Manoj. Thank you, Purvi, and thank you all for inviting me here. So without, already I am the last batsman. So my job is made simple by Dr. Gupta sir and Patni sir, because they have covered most of the things.
Sir, can you adjust your mic? The sound is not clear.
So thank you. First of all, let me thank Dr. Manoj Purvi and entire
Just
team of
raise it
DRS.
a bit. Yes.
Entire team of DRS. So actually, my job is made very easy by Dr. Gupta sir and Dr. Patni sir, because they have discussed many of these things, what I am supposed to discuss right now here. So my job is very easy. And yes, right now, what the prevalence of non-alcoholic fatty liver disease in India, it is really worrisome, because worldwide, it's almost 25% of population is being affected by metabolic associated or non-alcoholic fatty liver disease. And in India, if you look at the data, it's almost 38% of population is affected by non-alcoholic fatty liver disease. And those patients who are having metabolic disorders, 58% of patients with metabolic disorders, they are affected by MASLD. And very important, in pediatric population, almost 1/3 of pediatric group is affected. So this is, in future, this is very, very big problem. Right now we are facing, but we are still unaware of many of these things. If you look at the NAFLD and diabetes, those patients who are having NAFLD plus diabetes, in those patients, the fibrosis is very less, if just 29%, but the steatosis is very common. So whenever we see a patient with routine USG done for any abdominal problem, many times we see that fat percent is high or there is fatty liver disease, fatty liver, fat liver. So that should be taken in mind that these are the very important patient. We should go and go and investigate such patient. If you look at situation hand-to-hand type of comorbid condition with NMFLD, almost 90% patient of NAFLD, they are associated with obesity, 70% associated with type 2 diabetes, 68% associated with hypertension, high triglyceride and metabolic syndrome. So this is association. Nowadays, it has been labeled as, instead of NAFLD, we have labeled it as MASLD. It is a metabolic dysfunction associated with steatotic liver disease. A steatotic liver disease, that means a fat content of more than 5% associated with one cardiometabolic risk factor, which can be at high triglyceride, low HDL, type 2 diabetes or pre-diabetes, obesity, and high blood pressure. If one of the component, along with a liver fat content more than 5%, then we call it as a metabolic associated steatotic liver disease. And yes, here the liver is victim, and the root cause is insulin resistance, which leads to fatty liver disease. And the outcome of fatty liver disease, we know the cardiovascular disease, cirrhosis, hepatocellular carcinoma, as well as increased mortality. But the major outcome of fatty liver disease is not the cirrhosis or hepatic cellular carcinoma, but cardiovascular disease is the major problem. If you look at the data in 2020, 2002, that is Chennai Urban Population Study, which was published in 2002, the prevalence of insulin resistance was 11%, and the insulin resistance in middle income group as well as lower income group, there was significant difference. But right now, the prevalence is increased. If you look at this 2024 data, then the problem in India is basic problem. Whenever we want to do a screen a patient for non-alcoholic fatty liver disease, we go that yes, whenever the SGLT, SGPT is gone on higher side, AST, ALT on higher side, then only we screen. But important thing is the screening of liver fibrosis we should done irrespective of ALT, AST level, because look at the liver stiffness measurement. If it is more than 8, in spite of liver stiffness is high, then many of the time the, just a moment. Many of the time, the SGLT, SGPT levels, they remain normal. So in spite of normal SGLT, SGPT level, just by whenever we get a report of USG, any abdominal USG with high fat content, then we should do a liver analysis. And yes, I'm skipping some of the slide to prevent. And if you look at the diabetes patient with NAFLD and non-diabetic patient with NAFLD, so those patients who are associated with type 2 diabetes and NAFLD, their progress to NASH and progress to cirrhosis is little bit faster and higher. So look at this patient, NAFLD, non-diabetic NAFLD patient, just 10 to 20% they go in NASH, and just out of that patient, 10 to 15% go in cirrhosis. But those patients who are having NAFLD plus type 2 diabetes, 40% progresses to NASH, and out of that, almost 20-25% progresses to cirrhosis and hepatocellular carcinoma. So the complication of NASH is more common and more in type 2 diabetic patient with fatty liver disease. And here again, the slides, the most important cause of death in patient with MASLD is not liver related or malignancy related, but it's cardiovascular disease. And that's why it's considered as a very important risk factor for cardiovascular disease. It's very important, Dr. Gupta said right now, the knowledge of doctors and knowledge, attitude of doctors, practice of doctors is more important. And that's why it's very important to screen and diagnose MASLD. So this was in 2014, where just if you look at data, then has your doctor mentioned about liver disease? 98% patient were telling that their doctor do not mention that there is a fatty liver disease which is exist. But this is now newer data, where in 2023, almost 72% patients, they are heard of NAFLD. But the knowledge of MAFLD is still on lower side, and that is very important. So yes, these are the various, all the organizations which recommend screening of NAFLD in patient with obesity, type 2 diabetes, pre-diabetes with elevated liver enzyme, hypertriglyceridemia, low HDL, and patient with suffering from hypertension. So this is the recommendations. and algorithm how to go for MASLD if there is accidental or incidental detection of elevated liver enzyme or patient with all risk factors should do a liver screening through abdominal USG. So basic screening is USG, and USG is showing uh, if it is the fat content is high on USG, so liver fat is higher on USG, then you go for a FIB4 or NFS score. The NFS score, which directly, indirectly tells us that there is a fibrosis, because this non-invasive test or fibrosis, FIB4 score is very important. It's very sensitive marker for fibrosis. So if it is a chances of fibrosis are present, then we can, if it is low, then we can repeat every 2-3 years. If it is intermediate risk or high risk, then we should do a fibroscan test. And if fibroscan is normal, then repeat 2-3 years. If it is higher side, then definitely we have to take action. So FIB4 score is very simple. Officially, I can tell you that just download a app on, we are using Android mobile. So just age, AST, ALT level, and platelet count. These 4 parameters are required, and instantly, immediately, within seconds, you will get report in your Android mobile phone. And and it is very, very good tools to rule out fibrosis, hepatic fibrosis. So for fibrosis, FIB4 score is a very good sensitive and marker, highly sensitive as well as highly specific. And what is the vibration controlled transient elastography, or what we called it as a fibroscan? Fibroscan is a very good method, non-invasive method to look at the fibrosis part as well as steatosis part. The liver stiffness measurement, that is LSM, is actually a very good marker for fibrosis, and the CAP, that is controlled attenuation parameter, is very, very good marker of steatosis. So it indicate both the fibrosis part as well as steatosis part. Previously, we were thinking that liver biopsy is gold standard, but right now, the the data suggests that fibroscan is highly sensitive as well as specific for liver fat content as well as liver fibrosis content. So it's very easy to perform test, just 5 to 10 minutes job, non-invasive, and very, very, very easy to do it, and it's very reproducible. So how to read a fibroscan, that is very important. So there are LSM score, and there is CAP score. LSM score is fibrosis. So there is less than 7 is considered normal. If it is between 7 to 10, we consider as a mild fibrosis. 10 to 13, stage F2, moderate fibrosis. 13 to 16, stage F3, severe fibrosis. And more than 16, severe fibrosis, that is cirrhosis. And the CAP score for non-obese and obese patients, these are different. There are stage, it indicate liver fat content. So steatosis, stage 0, stage 1, stage 2, stage 3. So these are the how it is classification and how to manage. Yes, Dr. Gupta sir said, Dr. Patni sir said, how to manage. Basic is, and India is the first country where they have involved this NAFLD in non-communicable disease since 2021. So India is the first country where NAFLD is in, they are in their non-communicable disease program, and that is very good sign. So managing is lifestyle modification, diet and weight reduction is a cornerstone. Then apart from this, managing comorbid condition, particularly obesity, type 2 diabetes, that is another important thing. Third is pharmacotherapy, and right now the bariatric surgery. 4 are the important cornerstone. Best, yes, weight loss is very good method to give benefit for non-alcoholic fatty liver disease. But important thing, if you look at the data, more than 10% weight loss can reduce fibrosis in 45% of patients. More than 7% weight loss reduces NASH, hepatitis in 60 to 90% patient. But important thing, if you look at this portion, just after 1 year of treatment, only 10% of patient can maintain that, sustain that weight loss. Only 18% patient can sustain that 7% weight loss. So failure rates are very, very high, more than 80%, more than 90%. So we should keep in mind that lifestyle modifications do not work in 80 to 90% of patient. Then the role of saroglitazar. Saroglitazar, saro means good in Gujarati, and that we know. And this is the first Indian molecule. It is the first molecule developed from India. It's Indian molecule, purely Indian molecule, that is developed and approved for atherogenic diabetes dyslipidemia in 2013, and for non-alcoholic fatty liver disease in 2020, and this is global molecule now. It is not remained in India. It is now becoming global molecule. What is saroglitazar? It has a dual PPAR agonist. PPAR alpha, we know it's PPAR alpha is found in liver, kidney, heart, and important thing is it is a very important. It has a very important role in updation and oxidation of fatty acid, whereas PPAR gamma available it's seen on adipose tissue, and glucose, it's very important for glucose regulation, insulin resistance. So saroglitazar is dual PPAR gamma alpha agonist. Almost activity, alpha activity is 70 to 80%, and PPAR gamma activity just 20 to 25%. So PPAR gamma activity, it's for its insulin resistance benefit, and PPAR alpha activity, it's for triglyceride benefit. So that both activity is there. So these are the few of the studies which I'm quoting few of the data regarding saroglitazar, where it clearly said it increases insulin sensitivity as well as it benefits insulin metabolism. So baseline data after 4-month data, it benefits, particularly it reduces triglyceride by almost 40 to 60%. It reduces non-HDL cholesterol by 20 to 36%. It reduces small dense LDL, which are found to be more atherogenic, by 20%. It reduces HbA1c in the tune of 0.7 to 1.6%, and it reduces ALT level by almost 28%. So all the benefits, these are the analysis of 18 clinical studies, which encompasses almost 5,620. So the benefits are tremendous. This is evidence for study, because I'm right now saying that this molecule is not from right now in India, but we have developed this molecule, Indian company developed, but it's now global molecule. They have studied this molecule in US. What had they found that for actually the 104 patient on non-alcoholic fatty liver disease, 1 to 4 milligram of saroglitazar, 16 weeks treatment, you can read out from there. So benefit those patients who are taking saroglitazar 4 milligram, there is reduction in SGLT, ALT level, there is reduction in fat content, there is reduction in liver fat percentage by more than 10% and 30%. So 41% patient, the liver fat content are reduced by 30%, and almost 55% patient, the liver fat reduction is almost by 10%. So that is seen in this patient. So this is again NASH biopsy-driven study from India. So what they say that those patients, because previously we consider biopsy is gold standard for diagnosis NAFLD. So yes, those patients who are treated with saroglitazar, their biopsy proven benefit are seen in almost 53% patient population. This is also again a publication by our own Dr. Shubhankar Chaudhary, almost 112 patient tertiary care patient experience center. So what they say is that there is always benefit in the terms of from those patients who are in fibrosis stage 1 to those patients with fibrosis stage 2, 3, and 4. Everywhere you can see the benefit in reduction of fibrosis grade. Those patients who are on fibrosis grade 2, they have reduced to normalized or either 1 grade lesser in respective populations. So benefits are seen in across all populations. So right now, one doctor is asking the role of vitamin E, metformin, then UDCA and obeticholic acid. So yes, these are all the guidelines, like ESL guidelines, NICE guideline, ACF-ACP guidelines, AISF guideline, American Association of Study of Liver Disease guideline. They clearly mention that UDCA is not beneficial, not mentioned, or obeticholic acid also doesn't benefit. Only what benefits is, yes, it's PPAR gamma agonist in some of the patient. So these are the guidelines, pioglitazone particularly, but the role of pioglitazone is only in diabetic patient. Non-diabetic patient, we cannot use this molecule. Then these are the Indian National Association for Study of Liver. These are the 2022 guidelines, where they, again, for vitamin E, pioglitazone, and UDCA. So vitamin E, pioglitazone, and UDCA all are not approved for NASH or non-alcoholic fatty liver disease at all. So yes, saroglitazar, the association clearly mentioned the treatment for saroglitazar for NAFLD for minimum of 12 months. So indications are NASH, there is reduction in fibrosis, liver enzyme, and all the data, whether it's Indian or international, this favors this study. So it is actually the level of recommendation is one level of recommendations. So yes, what are the benefit of saroglitazar, UDCA, OCA in one slide? Saroglitazole reduces, improves insulin sensitivity. It's approved by American Association, NAFLD. It's approved in NAFLD, atherogenic, it approved in atherogenic diabetic dyslipidemia. There is reduction in enzymes, liver enzyme. There is reduction in fat content. There is reduction in NASH resolution. Hepatitis resolution is seen. And safety, yes, it's very safe. UDCA doesn't have any benefit. Only there is reduction in liver enzyme reduction is there. It's also very safe. Whereas OCA, vitamin E, they reduces the liver enzyme or liver fat content, but doesn't have a proven approval for NAFLD or there is reduction in hepatitis, which is biopsy proven. Pioglitazone, yes, it is a good insulin sensitizer. It reduces HGOT-PT level. It reduces liver fat content. But yes, there is NIOPS resolution also. But the major problem of pioglitazone is weight gain and edema, as well as heart failure in certain patients. So this is a head-to-head comparison. So first, ever in Indian guidelines, clinical cardiological society, they also approved uh, saroglitazole for atherogenic diabetic dyslipidemia or hypertriglyceridemia. Whenever the triglyceride is above 500 to 1000, the molecule saroglitazole is approved. And these are also Lipid Association of India, RSSDI 2022 guidelines, and Indian National Association for Study of Liver guidelines. They recommend saroglitazole for treatment of either atherogenic diabetic dyslipidemia as well as NAFLD. So yes, to summarize, metabolic associated liver disease, which is refined previously NAFLD is now refined as renamed as a MASLD. Association of at least one cardiometabolic risk factor like obesity, type 2 diabetes, pre-diabetes, hypertension, high triglyceride with steatotic liver disease as considered MASLD. Screening test like USG, basic test is USG and FIB4 score is very important for screening. And once if it is positive, then you should go for a fibroscan. Lifestyle modification is showing fantastic result, but the sustainability of lifestyle modification and weight reduction is a big question. And drug like saroglitazole is the only approved medication to treat NAFLD with metabolic disorder. Particularly, I'm saying with NAFLD with metabolic disorder in India, which can reduce liver enzyme, liver fat content, as well as it reduces fibrosis score as well. So thank you all.
So question one.
Please.
As you said, it is a 52-week study. Hmm? What will be after the 52 weeks if it is not taken? Whether it will reverse to the same thing or not?
Yes, sir. Actually, same for our obese patients, those who lose weight initially. Yes, there is benefit. But again, if they gain weight, then there will be again problem.
Because they are not gaining the weight. The effect, how much effect after the 52 weeks of treatment will last?
So, sir, these medication, these medication should be continued. Similar to like our statins, our metformin, our DPP-4 inhibitor, our SGLT2 inhibitor. This medication needs to be continued for lifeline.
And what I am telling is your treatment, which is your drug you mentioned, that if it study is up to
That study is 52 weeks. Yes.
Beyond that, if it is not there in the study,
yes,
in the remaining diabetes drugs, what you said is continue, and the lifestyle is all continue. So
Yes, sir.
whether it will increase or decrease, or it will remain the same.
Pardon, sir?
My question.
Pardon? Pardon?
Your effect of the drug.
No, sir. These medication needs to be continued because many
But
times
the
we do
study
have
is
a,
up to 52 weeks.
Those
Now
study-
the safety margin is not there beyond 52 weeks.
I think the basically the study patients, they are again investigated because initially we for SGLT2 inhibitor as well as DPP4 inhibitor, initial data is of 1 year. Then they after second year, they once they complete patient complete second year, they publish second year data. So once patient complete 102 weeks, they complete present 102 weeks data. So we will get that because this is 2023 data.
Yes, about this drug. But what about the SGLT2 remaining the anti-diabetic drug?
So their need should be continued.
But they have got the effect of this NFT.
Yes.
Yeah. Then that will suppose that medicine costly and it is stopped by the patient. So whether that benefit will vanish away?
Yes, sir.
Yeah.
That is true.
That is what I believe.
Okay, thank you very much, everybody. You have a Madam, we are already having the valedictory function in the Delhi hall. So just got a message. You can take him outside. Yeah. Thank you.
Thank you.
Thank you, sir. Wonderful talk.